No problem.
Great, perfect. Thank you. I'm going to go ahead and call to order the Patient Protection Commission meeting for May 15th, 2024. And we're going to start with roll call.
Thank you. Joseph Filippi for the record. Commissioners, please identify yourself when you hear your name called so that we can make sure you're present. I'm going to go ahead and start with our voting commissioners today. Commissioner Jalen Behunin.
Present.
Thank you. Commissioner Bio Curry Winchell.
Present.
Perfect. Thank you. Commissioner Walter Davis.
Present.
Commissioner Flo Khan just texted me, said there was some accident on the freeway, so she's going to be a couple minutes late. We'll mark her absent once she shows. Moving on to Commissioner Marilyn Kirkpatrick.
Present.
Commissioner Andrea Peterson.
Present.
Commissioner Bethany Sexton.
Present.
Thank you. Commissioner Wendy Simmons.
Present.
Thank you. And Chair Ikram Khan will be marked absent excused. He had a family emergency and is unable to attend today. Vice Chair Kirkpatrick, we do have a majority of members present, so we have quorum and can proceed. Forgive me, sorry, I forgot to do a roll call for our ex officio non-voting members. So really quickly, Insurance Commissioner Scott Kipper, I believe, was unable to attend. I believe Glenn Shippey is attending on his behalf. Can you let us know if you're present?
Glenn Shippey is present. Thank you.
Thank you. And Director Richard Whitley with Health and Human Services.
Present.
Thank you. Executive Officer Celestina Glover.
Present.
Thank you. And Executive Director Russell Cook.
Present.
Perfect. Thank you so much. We do have a quorum, and Vice Chair, we can proceed.
Great. Thank you, Joseph. And again, I apologize for a little bit of background. I'm multitasking. I'm at an elementary school, so it's 3 days before school gets out. It's a little bit crazy. But I want to start off with the Patient Protection Board is an important role that we play going forward for the state as a whole. But most importantly, this month of May is Mental Health Month. And as you all know, that is an important task that is before us, that we have to ensure that people have the awareness and they know where to call in the event that they have need. And I want to take a personal privilege and remind employers that, you know, if you can help your employees when they're in a time of need, that's really important to ensure that they have that stability. So if I could just remind the community that if you need to call someone, if you're in crisis or know someone in crisis, you can dial 988 and we will get you some assistance as soon as possible. So thanks to this board for serving, and mental health awareness in May is very important. So thanks. Joseph?
Thank you, Marilyn. I think we're moving on to agenda item number 2. Do you want me to go ahead and start that, Vice Chair?
No, I can go on to item number 2. And each commissioner, we're going to ask that each commissioner introduce themselves, state the position they represent on the commission, and provide a brief description of their professional or personal backgrounds. In consideration of time, if you could limit that to 1 to 2 minutes, and then we'll start with our voting members. So Joseph, if you want to call on those as we did and roll, that would be great.
Sure, absolutely. So if Commissioner Jalen Behunin, if you don't mind, go ahead and introducing yourself.
Sure. Hi, my name is Jalyn Behunin. I am representing the RN working at a nonprofit. I've been a nurse for about 30 years, originally from Southern Utah, but I've been here in the Henderson area for about 15. I work at Dignity Health St. Rose, San Martin. I've been here the whole time. I came here as a staff nurse. My background is in intensive care. I kind of stepped up the ladder into leadership positions as manager, senior director, and I stepped into the chief nurse executive role in 2020. And so it's my honor to advocate for nursing on different platforms, and honored to represent nursing on this committee. Thank you so much.
Awesome. Thank you so much for being here. Commissioner Dr. Bio Curry Winchell, can you introduce yourself, please?
Hello, everyone. I'm Dr. Bio Curry Winchell. I'm the medical director of St. Mary's Urgent Care Services, as well as the founder of Beyond Clinical Walls, which is a health and video series that really raises awareness and shares solutions on how to really inform yourself, know about health, and what you can do about it. So, health equity advocate here in Reno, Nevada, and a practicing physician. So, excited to represent physician and community engagement and so forth.
Thank you. Commissioner Walter Davis, can you introduce yourself, please?
Thank you. Good morning again. My name is Walter Davis, and I represent the Federally Qualified Healthcare Center arena. I've been with Nevada Health Centers for the last 12 years, going on 13 years now. And I have offices both in Reno, or Carson City rather, and then also in Las Vegas. And so I'm happy to be a part of this and talk about the healthcare disparities and issues that will help align us in the workforce space as well. So thank you very much for today's opportunity.
Thank you. Commissioner Marilyn Kirkpatrick.
Thank you. I'm Marilyn Kirkpatrick, and I sit on the Clark County Commission. I represent the county hospital. So I look forward to being part of this and addressing many of the issues that are important.
Thank you. Commissioner Andrea Peterson.
Thank you. My name is Andrea Peterson. I am representing underserved populations. I'm a pharmacist by background. I spent 13 years working in the newborn intensive care unit and maternal child areas. And then I am currently the executive director and co-founder of the Empowered program. And so we support pregnant and postpartum individuals experiencing substance use disorders. Thank you.
Thank you. Commissioner Wendy Simmons. You're muted, Wendy.
Apologies for that. I believe I represent, it's been a while since we started, the public and a person with experience. Just by way of quick background, my parents started the first senior care in Nevada in 1948. Born and raised in the old folks home, 37 years as an owner, operator, administrator of long-term care facilities. Then had a privilege of working under Richard as a compliance consultant and ultimately his bureau chief for regulatory. Retired from there and was recruited to serve with the Nevada Department of Veterans Services, the veteran population of suicide prevention, homelessness, long-term care, and other areas, of interest. Retired from that in 2020. I don't retire very well, so I'm in my 5th retirement assignment. But love serving the public, love serving those who have taken care of us and grown with us, love serving employees and employers of healthcare. And currently just put my 95-year-old sister on hospice. So we're a family journey of many, many years in healthcare and very gifted to have been there. Thank you.
Thank you so much. We can go ahead and move over to our ex officio non-voting commission members. Director Whitley, do you want to introduce yourself, please?
Richard Whitley. I serve as the director for the Department of Health and Human Services and have been in this role since 2015, but really a lifelong public servant and proud to be. That's really all I have.
Thank you, Richard. Glenn, do you want to go ahead and introduce yourself from Division of Insurance?
Sure, Joseph. I'm Glenn Shippey. I'm the Chief Insurance Examiner of the Life and Health section of the Division of Insurance. Thank you.
Thank you. Celestina Glover?
Yes, I'm Celestina Glover. I'm the Executive Officer for the Public Employees Benefits Program. I've been in this position about a year. Before that, I was the CFO for about 7 years. Then I retired, and I too apparently don't do retirement well. So I am back.
Happy to have you. Thank you. And Russell Cook?
Thanks, Joseph. My name is Russell Cook, and I was appointed Executive Director of the Silver State Health Insurance Exchange last August. I've worked with the exchange since 2016. Before my director position, I was our information security officer, and we run the Nevada HealthLink Marketplace platform with over 100,000 Nevadans enrolled in Affordable Care Act quality health plans, and I'm privileged to be here representing those interests. Thank you.
Thank you. Bethany, you have your hand raised?
I just was going to introduce myself. That's okay.
I'm so sorry. Did I go over you? I apologize for that. Please
Totally
introduce
fine.
yourself. Last but not least, please.
Good morning, everybody. I'm Bethany Sexton. I'm the CEO for Hometown Health, filling the role of the not-for-profit health insurer. Have been at the broader Renown Health organization for the past 10 years and worked within healthcare, mostly actually on the provider side, for the better part of 2 decades. So nice to meet everybody.
Thank you so much for that. I'll quickly introduce myself, Joseph Filippi. I'm proud to serve as the Patient Protection Commission's Executive Director. I'm very new to this role, was recently appointed in April of this year. Look forward to serving you all. A little bit of background, I'm a native Nevadan, grew up in Northern Nevada, born in Elko, raised in Carson City area. I've served in state service for the last 10 years, many of those years with the Department of Health and Human Services. Served during the COVID pandemic as executive assistant for public and behavioral health, supported several different healthcare boards during that time. Served as legislative liaison in the director's office for a time as well. Just really excited to be here. I think this is a really important public body and look forward to supporting you and the important work ahead. So, Chair, I think we're done with this agenda item. I think you're muted, Marilyn. We might be having technical difficulties, so what I can do is I think I'm the next agenda item anyway, so let me go ahead and share my screen and we'll get going on the next agenda item. Oh, I'm so sorry. Public comment, most important probably of the meeting. So let me backtrack a little bit. The third item on the agenda offers an opportunity for public comment. So no action can be taken upon a matter raised under public comment unless the matter itself has been specifically included on the agenda as an action item. To provide public comment over the telephone, please join the meeting by dialing 775-321-6111. And when prompted to provide the meeting ID, enter 902-117-927#. You may then press *5 to raise your hand over the phone. If you're joining by the computer, please use the raised hand function at the top of your screen. Persons making comment will be asked to begin by stating their name for the record and spelling their last name, and each comment will be limited to 3 minutes. So if there's any public comment, please go ahead and raise your hand by pressing *5 or using the raised hand feature. Looks like Dan Musgrove, you have your hand raised. Go ahead and start, please.
Well, thank you. My name is Dan Musgrove. That is Musgrove, and I'm here on behalf of Nathan Adelson Hospice, one of only 2 nonprofit hospices in the state of Nevada and the only one operating in Clark County. I just wanted to put something on the radar of the Patient Protection Commission because I think it falls directly in your role in that we have seen a huge influx of in-home hospice care here in Clark County. Beyond what any would expect. What happened is a couple of years ago, California instituted a moratorium because they could see that there was a lot of fraud and abuse taking place. We've seen a number of those operators come now into the state of Nevada, Arizona, and Texas. And what we're seeing is that seniors, loved ones of families that are facing that end of life decision, much as Member Simmons just talked about, are being taken advantage of because they don't understand what they should be getting under hospice care. These in-home hospice operators get them signed up and then are not providing any service. As an example, Nathan Adelson Hospice normally only gets maybe 4 transfers a year from hospice care. And we are seeing transfers anywhere between 2 and 4 transfers per week of folks that are not receiving proper care under the in-home hospice care that they were expecting to. And it's a real tragedy for these families and loved ones that are undergoing this transition to the end of life. And it's certainly not an issue for us in terms of competition, but we believe that it is a very serious matter for the healthcare that these folks endure. So we've asked for a moratorium of the governor. I'll be happy to provide that letter on the record to you, so you have a copy of it. But we would love an opportunity maybe to give an extended agenda item to you to talk about this and bring folks from Nathan Adelson Hospice to discuss the issues they're facing. So thank you for the opportunity to discuss this in public comment.
Thank you, Mr. Musgrove. Carissa Pierce, please start when you're ready.
Good morning, everyone. My name is Carissa Pierce, P-E-A-R-C-E. Thank you for the opportunity to provide comment today. I am the health policy manager at the Children's Advocacy Alliance, and we are a nonpartisan, independent nonprofit. We work with public policy to try to allow every child in Nevada to thrive. And we strongly support action that increases access to and delivery of mental and behavioral health resources. We're supporting the work in item 9 that is presented today by Michelle Paul and Sarah Hunt. They are incredible partners in training the child behavioral health workforce, and we are supporting their efforts to bolster degree programs.
Is that the one I just gave you?
Yeah, because sorry, excuse me. And the post-degree training programs. We have amazing programs in our state, but they need more investment to recruit students at bachelor's, master's, and doctoral levels. And we want to improve our ability to deliver care by starting to grow our own providers. We also need a strategy to retain practitioners in the state after they complete their program. The Office of Medicaid is already working to improve the licensure practice for practitioners, but there are other strategies that we can look into, such as reviewing the practice scope for PAs, considering state level leadership, and working on our centralized information through a centralized data hub. Related to PAs, in Nevada, PAs have extremely limited range of how they're able to practice without the oversight of a physician in their exact area of practice, which majorly reduces the number of children and adolescents who are able to be seen by these practitioners. And it's not aligned with the scope of practice in other states. In written comment, I am submitting a resource that explains how scope of practice has been expanded in other states, and we feel Nevada should consider modeling our scope of practice to expand those other capacities. We convene a coalition on children's mental and behavioral health, and I will also submit written comment that it goes into some of our other ideas, including the state level leadership and centralized information that I mentioned. So thank you so much for your time.
Thank you, Ms. Pierce. Appreciate you submitting additional comments. We're going to go ahead and take it to caller ending in 5820. Go ahead and state your name. #5820. If you want to press, I believe it's *8 to unmute.
Hi, Joseph. Good morning. This is Andrea. Can you hear me okay?
Andrea, yes, we can. Please state your last name and spell it for the record, please.
Perfect. Thank you. Good morning. My name is Andrea Gregg. My last name is G-R-E-G-G. I'm the CEO of High Sierra Area Health Education Center, also known as AHEC. Considering today's agenda and the Commission's interest in workforce development programs throughout the state, I'm excited to bring your attention to the Nevada AHEC program. I've also submitted written testimony that further details our commitment to this work and the positive impact that our programs are making to help meet our state's healthcare workforce needs, one student and one success story at a time. High Sierra AHEC focuses on community needs by forming strong academic and community partnerships that aim to recruit, train, and develop our healthcare workforce. We do that work beginning as early as 5th grade and extend through all of our advanced programs. We're also an approved community health worker training provider, currently serving as a talent acquisition partner for those looking to utilize CHWs within their communities. And through education, mentorship, and engagement, we're shaping highly skilled healthcare leaders, benefiting both of our communities and our partners. Given the impressive lineup of participants on today's agenda, many of whom have long championed our mission, I wanted to emphasize our commitment to adapting programs to meet our partners' evolving needs, sharing with each of you that our approach is very intentional as we aim to directly align with and enhance the formalized plans of our valued partners statewide. As you navigate this critical area, we encourage you to consider Nevada AHEC program not just as an option, but also as a strong partner in shaping the future of healthcare workforce development in our state. Thank you.
Thank you, Andrea. Appreciate your comment today. If there's anybody else wishing to provide public comment, please raise your hand over the Teams application or press *5 if joining by phone. Vice Chair, I believe there's no further public comment. Unfortunately, still unable to hear you, Marilyn. Perhaps we can try calling in to the meeting. Sorry about that. So I'll go ahead and move on to agenda item number 4, which is the presentation on the Commission's purpose, responsibilities, and duties. So give me one moment to share my screen with the group. All right. Can someone confirm that they can see my screen? Okay, perfect. Thumbs up. Thank you so much. So good morning, everyone. Good morning, everyone. Walter, what'd you say? Sorry about that.
I'm sorry, I see it now. It just showed up.
Oh, you can see it now. Perfect. Okay. Sorry if there's any delay there. Good morning, everyone. Again, my name is Joseph Filippi. Proud to serve as your Executive Director for the Patient Protection Commission today, also known as the PPC. Today, I will provide an overview of the Commission's purpose, further details about the duties and responsibilities assigned to the Commission. So a little bit of background on the PPC. In 2019, the Nevada legislature approved Senate Bill 544, which created the commission to systematically review issues related to healthcare needs of Nevada residents and the accessibility, affordability, and quality of healthcare in the state. Moving to 2021, Assembly Bill 348 moved the PPC from the governor's office to under the Nevada Department of Health and Human Services. This was to help support patients and connect the commission with more data and resources that the department has. The bill also revised some membership of the positions on the commission. It added additional responsibilities and required the PPC to adopt bylaws. For anyone interested, the statutory authority of the PPC can be found in Nevada Revised Statutes, Chapter 439.902 through 918. Membership. So the commission's membership is comprised of 12 voting members who are all appointed by the governor. These members are from across the healthcare spectrum. They include advocates, providers, and industry professionals dedicated to improving healthcare in Nevada. Additionally, the PPC is fortunate to have representation from the state agencies tasked with providing healthcare services, regulating healthcare, and offering health insurance. They introduced themselves earlier, but these ex officio non-voting members, they are Richard Whitley, Director of Health and Human Services, Scott Kipper, Insurance Commissioner with the Nevada Division of Insurance, Russell Cook, who is the Executive Director over the Silver State Health Insurance Exchange, and Celestina Glover, Executive Officer of Public Employee Benefits Program. So the current commission members, currently there's 9 of the 12 voting member slots appointed. The current members are Ms. Jalen Behunin. She serves as the registered nurse who primarily practices at a nonprofit hospital. Dr. Bio-Curry Winchell and Ms. Wendy Simmons both serve as the members who have expertise and experience in advocating on behalf of patients. Mr. Walter Davis has expertise and experience in advocating for persons who are not covered by a policy of health insurance. Ms. Florine Kahn represents the general public. Dr. Ikram Khan, who's the chair, is a provider of healthcare who operates a for-profit business to provide healthcare. Ms. Marilyn Kirkpatrick represents a nonprofit public hospital who's located in the county of the state that spends the largest amount of money on hospital care for indigent persons. Dr. Andrea Peterson, who has expertise and experience in advocating for persons with special healthcare needs and has education and experience in healthcare. And Ms. Bethany Sexton, who represents a private nonprofit health insurer with the highest percentage of insureds in the state who is adversely impacted by social determinants of health. These three positions are vacant on the commission. For sake of time, I'm not going to go over every position there, but any individual who's interested in serving on the commission is encouraged to apply through the governor's office website linked here. Commissioner Kirkpatrick, you have your hand raised. Might be technical difficulties still. Okay, moving on. Let's move into the PPC's responsibilities. So here's an overview of those. The responsibilities of the commission can be found in Chapter 439 of NRS. NRS 439.916 provides the commission with broad authority to systematically review issues related to healthcare needs of Nevada residents, and also review quality, accessibility, and affordability of healthcare statewide. The commission's also charged with making informed recommendations to the governor, the legislature, and other government entities. Additionally, responsibilities under NRS 439.918 request the PPC to collaborate and coordinate with existing state government entities that study or address issues related to healthcare access, quality, and affordability. And additionally, without limitation, this includes collaborating with the regional behavioral health policy boards. Other duties are to utilize health data to establish priorities to improve access and quality of healthcare in Nevada and ensure that that health data is publicly available and transparent. Also establish and annually update a plan to increase patient medical record access and interoperability. And they are also required to prepare a semi-annual report on commission activities. A little bit further into the PPC reports that are required. The PPC must provide a semi-annual report to the governor and the legislature. This report must, it offers the PPC with a frequent opportunity to summarize their activities, share any identified issues impacting quality, accessibility, and affordability of healthcare, and it also allows them to provide recommendations to address the issues identified. Additionally, the PPC must establish and annually update a plan to increase patient access to medical records. Moving on, I'm going to now provide an overview of the Nevada legislative process, just a general overview, the PPC's ability to draft legislative measures, and also a little bit of history on some of the bills that the PPC has helped enact. So overview of the Nevada legislature. Our legislature meets every other year for a 120-day session. It's very quick. During this time, they adopt a 2-year budget and enact new laws or revise existing laws. These ideas are drafted as new legislative measures, and they're often referred to as bill draft requests or BDRs. These BDRs are submitted to the Legislative Council Bureau, proposing additions, deletions, and/or changes to NRS. As you can see in this infographic on the slide, developed by the legislature, the bill draft is the beginning of a longer legislative process. Once the session begins, a BDR must be assigned a bill number and referred to a committee. From there, it goes through committee hearings and House floor debates in each house. If the bill passes both the Assembly and the Senate, it is then brought to the governor, who may choose to sign it into law, allow it to go into law without signature, or also veto it. A veto override requires a 2/3 majority vote from each house of the legislature. Some things to remember when developing BDRs. Pursuant to NRS 218D.213, the commission may request the drafting of not more than 3 BDRs, which relate to matters within the scope of the commission. Each BDR must be limited to one subject, and the BDR may contain proposed revisions to more than one chapter of NRS, but they must still relate to that single subject of the proposed bill. And then finally, PPC BDRs must be submitted to the Legislative Council Bureau on or before September 1st, prior to each regular legislative session. This slide provides an overview of enacted bills that the PPC has brought forward. So in 2021, Senate Bill 5 required DHHS to establish a data dashboard for data relating to telehealth access in the state. Also in 2021, Senate Bill 40 established an all-payer claims database, which allows Nevada to collect data to improve healthcare transparency, and also allows us to examine the cost, quality, and utilization of that data. DHHS is currently in the process of establishing regulations for the database and has procured a vendor to begin creating the all-payer claims database. Moving on to last session in 2023, Assembly Bill 7, which mandates all providers of healthcare, unless otherwise exempted, implement an interoperable electronic health record by January 1st, 2030. The department is still implementing this bill. I intend to keep the commission updated on the progress of the implementation. Mostly due because NRS 439.918 does require the commission to increase patient access to medical records and also increase the interoperability of medical records among healthcare providers. I will now provide an overview of the recent governor's executive order. So on April 11th of this year, 2024, the governor signed Executive Order 2024-002, directing the PPC to make recommendations aimed at addressing the state's healthcare workforce shortage, so more Nevada patients have access to quality healthcare statewide. The executive order directs the PPC to review available data and national best practices to provide recommendations for the following areas. A, attracting and retaining talent to address healthcare workforce challenges in urban and rural communities. B, improving access to primary care and public health services. C, removing unnecessary state administrative hurdles to recruit and retain healthcare workers. D, identify and sustainable funding strategies for strengthening the state's healthcare workforce. This includes supporting competitive Medicaid rate reimbursements. E, ensuring recommended strategies for increasing provider reimbursement are based on payment methodologies that incentivize and reward for a better quality and value of the taxpayer dollar. And finally, F, identifying strategies for evaluating new and existing state investments in efforts to improve the capacity and the size of the state's healthcare workforce. So this slide represents proposed next steps for the commission to consider as we review available healthcare workforce data and provide necessary recommendations. Per the executive order, recommendations to address healthcare workforce shortages shall be included in the semi-annual report required to be submitted. As previously stated, these reports are required to be submitted each year by January 1st and July 1st each year. In addition to providing recommendations in the semi-annual report from the commission, the PPC may request up to 3 BDRs for the upcoming 2025 legislative session. These must be submitted, as we said earlier, by September 1st of this year, 2024. As you can see in the proposed timeline, it would be ideal for the commission to determine some initial BDR concepts by July and then finalize up to 3 BDR concepts by August prior to that September 1st deadline. I understand it's a tight turnaround, but I believe it's also a great opportunity for us as a commission to bring forward some ideas to this next session. This outline presented before you is fluid. It's meant to serve as a guide as we plan for next steps and future meetings for the remainder of this calendar year. On this slide is my contact information. Feel free to email or call me anytime. Additionally, anyone who's interested in the PPC, I encourage you to sign up for our listserv, which is found on this link here and on our website. And with that, commission members and vice chair, I'm ready for any questions that you might have. Sorry, Marilyn, we still can't hear you. I'm so sorry. Are you able to call in with your cell phone? Okay, we'll try that. Any other commissioners, do you have any comments, questions you'd like to discuss? Not hearing any. Okay. I think we can move on to the next agenda item, which is a presentation on Nevada's open meeting laws. Today we have our Deputy Attorney General, Gabe Lither, who's going to provide a general overview of Nevada open meeting laws. Let me go ahead and pull up that presentation for you, Gabe.
Thank you. As indicated by Joseph, my name's Gabriel Lither, Gabe, and I've been with the Attorney General's office for, gosh, since 99, so 24, 25 years. Almost all of that with representing Medicaid, 23 years representing Nevada Medicaid, which I think is a record for any DAG, I'm sure it is. Not that Medicaid's a tough client, I love representing Medicaid. One quick comment on my end, I should say that my eyes are watering for some reason. Once the air conditioning came on in Grant Sawyer building, my eyes have been watering like crazy the last 5 or 10 minutes. You guys are not making me cry. It's just the air conditioning for some reason. All right, let's go ahead and have the next slide. We're going to have a brief meeting about the Nevada's open meeting law. This was prepared by Rosalie Bordalov, this presentation, but I made some edits and changes to it and want to go ahead and have this discussion. I feel a little bit strange here presenting this to you because I know that many of you have a lot of experience with the open meeting law, and this is not meant to go extremely in depth, but will hopefully be a good refresher about the basics of what the open meeting law requires. So first, this presentation is going to answer 5 questions. What is the open meeting law? When does it apply? How do I comply with the open meeting law? What happens if it's violated? Hopefully it isn't violated ever by this particular commission, but what happens if it is violated? And then when do members of a particular board need to disclose or abstain from taking a vote? So let's go ahead and go to the next slide. The open meeting law. The open meeting law is adopted by NRS Chapter 241. There are a lot of chapters in the Nevada revised statutes, as we all know. Many of them are very, very convoluted and complicated. This particular chapter I appreciate because it's actually very short and yet very, very important. It's that in one of the things that's stated in that chapter is that in enacting this chapter, the legislature finds and declares that all public bodies exist to aid in the conduct of the people's business. And I know that there is a lot of concern nationally and at the local levels about governments taking action kind of behind closed doors. And the open meeting law ensures that the people's business is done in a very transparent manner and that the public knows what's going on and backroom deals aren't being made. Okay, next slide. So when does the open meeting law apply? Obviously it applies if we're having a meeting like we're having one today. It applies to all meetings of public bodies in the state of Nevada, and there is a detailed definition of public body in the open meeting law statute. But generally, public bodies are bodies created by statute, executive order, or by action of another body. And that includes subcommittees of that body. A meeting under the open meeting law, a meeting requires both a quorum and either deliberation or action. Quorum means a simple majority of the total body or other proportion established by law. It's almost always a simple majority of the total body, but there are a few exceptions in various places about when actions can occur and what is required for a quorum. And deliberation means collectively to examine, weigh, and reflect upon the reasons for or against an action. Action means majority vote of the members present. Next slide. So one important thing to note is that a gathering of a quorum at a social function or for training is not a meeting as long as there is no deliberation or action. And this is a big important but, and it's that it actually can, if there's a majority of members present at a social meeting and there is deliberation on something that was within the purview of something that should be discussed at a meeting or within the purview of that commission, that could constitute a meeting outside of a regular meeting. So obviously that's something that should not occur. Related to that, electronic communication between a quorum of members can also constitute a meeting. And one pitfall that we've seen frequently is when people use the reply all. So one email goes to one member of the commission, they reply all to everyone talking about something related to an action. And next thing you know, there has actually been a meeting that should not have occurred. So serial communications and walking quorums can constitute constructive meetings. What we mean by serial communications is if we have a seven-member body, for example, and 3 members discuss an issue after a meeting, one member of the 3 then speaks with another member a week later and conveys the opinions of the others, then 4 members of that body have now collectively deliberated on an issue outside of the meeting, which is something that must be avoided. Let's go to the next slide. How do we comply with the open meeting law? Next slide, meeting notice and agenda. So the notice of the meeting must include the time, place, and location, information on remote technology systems, which is just so much more important than it was 5-10 years ago, right? I mean, I think in part thanks to COVID, we now have so much more technology. It's interesting. I never thought, 5 years ago, I'd be involved in debates about what's better, Teams versus Zoom versus Blue Jeans and things of that nature. But now those are just things that we all know what they are. We all wish we bought stock at the beginning. It's just, yeah, we have a lot more remote technology systems than we used to have. The agenda must also include name, contact, and business address to receive supporting material, the location, clear and complete statements of topics. This is important because any action must be obviously agendized, and the agenda must include, it must be reasonably sufficient so that an individual of the public, when they read that agenda, they know what action is going to be taken. So the agenda must include clear and complete statements and can't just include such generic things as, member comments or generic reports, action on reports. It needs to be clear and complete so that individuals actually know what's going on. There must be an opportunity for public comment, period. And all of these requirements are found in the NRS 241. Must be posted several days before the meeting, and notice must be sent to people who have requested notice of meetings. Also important. All right, let's go to the next slide. Public bodies shall make reasonable efforts to assist and accommodate persons with physical disabilities desiring to attend. I always think this, for Medicaid, I mean, I know it's important. Obviously, it's important with this particular commission as well, because so much of it deals with healthcare. Who's interested in healthcare? A disproportionate number have disabilities or know people who may be people with disabilities. So it's obviously important that they be able to attend as well. That's a requirement by the law. The meetings must be recorded or transcribed. Minutes must be kept, and supporting materials must be available to the public at the time is provided to the members of the public body. I would say about the agenda, probably one of the issues that we see the most often is when an entity wants to take something, action on an item, and there is something on the agenda that's been agendized, but the actual, the board, the commission starts to veer off just a little bit into an issue that's not particularly agendized. And when that happens, council and the chair will indicate, this is a great discussion, but it's actually not agendized. Let's put this on a future agenda so that it can be, notice can go out to the public and we can all take action at that time. All right, next slide. Public comment. So the minimum requirement for public comment is first to provide general or limited to agenda items prior to any action item, as we did today, or on each action item after discussion but prior to a vote, and general public comment period at some time prior to adjournment. I should note that, the more public comment, the more better. So, so it's not like if you guys decide to have, it's agendized that we're having public comment at the beginning and at the end of the meeting, there's nothing to prevent the chair from calling on additional public comment at some point. It's fully allowed. Restrictions can be placed for reasonable time, place, and manner, especially if something were to be so contentious that there start to be hundreds of people who want to speak out. Frequently, they'll make, limit it in some way for time, but it must be neutral as to any restrictions that are placed on those public comments. It must, this is a new addition in 2023, if using remote technology systems, must offer at least telephonic public comment. I would say that public comment, it's really important that people be given the opportunity to provide public comment, obviously. It's some meetings where public comment is almost like, I've said this before at other meetings, it's kind of like the old Seinfeld episode where it's the airing of grievances, right? The public just wants to get something off their chest. But for entities like this one, public comment is important because it actually helps inform, advise, steer the members of the commission, the chair, into future action items that they may want to take. So obviously, it's very important that we receive that. All right, next slide. Complying with open meeting law. Members of the public bodies can attend virtually, whether or not there's a physical location for the public to attend. If no physical location for the public, virtual attendance options must be provided. Public must be able to hear and observe to the same level as members. So the pitfall here that we have is that there is a chat function with most of these technologies that allows chats to be going on. Even if you weren't using this particular technology, we all have cell phones and you could be texting each other during the meeting. And frankly, the members of the public would not be able to see who's on their cell phones or who's texting who during the meeting. And that's something that we want to avoid. All deliberations should be occurring in public so that everyone can see them. The one exception that I and many other council have allowed is that if we were to see that there is some issue caused by technology of a temporary nature, so that somebody is a member of the body is not able to speak for some reason, but can use chat to vote yes, then I think that most of us allowed that to occur, that vote to occur, use the technology to do that, and then move on and get them access to a method so that they can communicate and fix that technology issue. All right, next slide. What happens when the open meeting law is violated? Most importantly, the actions taken in violation of the open meeting law are void, and the Attorney General's office has authority to investigate and prosecute violations. I will say that that's extremely rare. Our office puts out press releases that go around internally via office email when it takes actions against various entities. And I can't remember the last time we criminally charged. I'm sure it's happened, but it's very rare. It would have to be a repeated willful violation where, for example, a member of a commission went out there and knew they weren't supposed to be speaking outside of a public body to others about a particular issue, but kept doing it repeatedly anyway. So that's extremely, extremely rare. But it does happen that violations occur. And when that occurs, most important thing is to try to take corrective action as soon as possible. It doesn't eliminate the violation, but it can mitigate the severity of the effects. Next slide. When to disclose or abstain. Disclosure is mandated for any interest created by, and things are listed there. I'll just say about this particular slide, we understand that sometimes there are things that come up that may require disclosure, but actually abstaining is only required in clear cases where the independence of the reasonable person in that situation would be materially affected. So disclose frequently. Actual abstention is very, very rare. So generally that doesn't occur, but if you have questions about that, contact Joseph. He'll work with either me or another member of the Attorney General's office, and we would determine that. One additional point that I did want to make is that, especially in certain public bodies, there is a question as to, the state or the agency who's helping guide that particular public body may have some information or some outcome that they're presenting. And I think it's important to remember that, these public bodies and this public body in particular None of them are rubber stamps. They should not be rubber stamps. That's not what the open meeting law is about. That's not why we do it transparently. It's not to be a rubber stamp. What it is that to get the information from the expertise from those individuals who are actually on a commission like this one. And to do that, not only do we not want a rubber stamp, but when actions are taken, even if it is to approve, unanimously the action that the state is proposing, it's always helpful to get the dialogue and the discussion from the members of that committee, from the members of that commission, because that dialogue and that discussion can help further, future actions that the chair and that the members, the state agency help propose down the road. Lastly, I've got a link here. It's got the Nevada Open Meeting Law manual to it, which is a great manual. I sometimes joke about how it will put you to sleep, but actually it is a great manual and a fantastic resource, as well as just NRS Chapter 241 in general. With that, any questions? All right, then thank you. I'll just pay attention to the rest of the meeting. Thanks.
All right, Joseph, fingers crossed. Can you hear me?
Yes, we can. Thank you so much.
Thank God. I was feeling frustrated. I apologize. Thank you for that information. And I just want to point out for the commission that Joseph did a really great job of putting all of this in your backup. So if you have any extra questions going forward, then you have all the perfect links to do that. So the next item is item number 6 is a presentation on healthcare workforce challenges facing Nevada and policy considerations. And I just want to note that I have a hard stop at 11 myself. There are some members that need to leave about 10:30. So if we could do the high level, because we got such great backup, then we'll have plenty of time to answer questions, if that's okay with the presenter.
Thanks, Marilyn. Thanks, Commissioner Kirkpatrick. Dr. Packham, are you able to go ahead and pull up your slide deck?
Well, you would think after 4 years of the pandemic, I'd be able to do that. Do you have that accessible, Joseph?
Yes, give me one moment.
It's a technology day for everybody, I think.
That's why I told Joseph to just run mine. I knew something like that would happen.
Outstanding. Thank you so much. Well, good morning. It's my pleasure to provide an overview of health workforce challenges facing Nevada and a discussion of policy measures that the state might take to address those shortages and increase the supply of physicians, nurses, and other health professionals. A lot of the information I'm going to be sharing with you has been produced by the Nevada Health Workforce Research Center, which is based at the University of Nevada, Reno School of Medicine. On this slide, I've listed some resources. I'm hoping a couple of those publications, the data book and the healthcare careers manuals, have been sent to commission members, hard copies. I'm happy to email PDFs of anything I referenced today for the commission's pleasure. And one of the things that I wanted to state at the outset of this discussion, and I'll conclude with the same remark, is I hope the commission considers our office as a resource as you explore health workforce trends and what to do about them as a commission. I think the fact that you have an opportunity to submit 3 bill drafts that address workforce issues is significant. And I hope my office can complement or support those efforts as well. I wanted to begin today not by going through this entire slide. I promise I won't do this. This is an entire course in health policy in Nevada, but just note that state lawmakers face a number of healthcare and public health challenges. Currently, I've listed all I could cram onto one single slide with this slide here, but wanted to make the point that if you look closely at each one of these issues, there's a workforce component to it, either directly or indirectly. And so as you deliberate or think about what you might pursue as a bill draft request for the 2025 session, be mindful that you may not necessarily be competing if, again, we're addressing workforce issues. There was a task force meeting yesterday on Alzheimer's disease, and it was kind of one of those sobering reminders that the level of need in Nevada and the resources and workforce in place, that gap is huge. And so a lot of issues competing for the attention of lawmakers in that brief 120-day session, but I would contend many of those have workforce issues that, again, your commission has the opportunity to address. Next slide. Similarly, I like to make the point in these presentations that health workforce development is economic development. The health sector and the medical sector doesn't always necessarily get the focus or the attention of economic development folks at the state or regional level. But I would like to argue that when the state is addressing health workforce development, we're also complementing and pushing the broader agenda of economic development and diversification. You will never get a business to relocate to Nevada unless you have a robust healthcare sector. You will never get retirees to consider Las Vegas or Mesquite or other parts of the state as a retirement destination unless you have a robust healthcare sector. So as you think about what we can do to address shortages, I would argue that if you're doing that, you're also helping to support the broader agenda of economic development in this state. Next slide. In this slide and the following, I'm going to just really provide a high-level overview of what is driving health workforce demand in Nevada, and then follow that with a summary of kind of the general or major trends in health workforce supply. I'd like to note it's kind of a pleasure giving this discussion in 2024 versus the previous couple of years, because I think some of the disruption caused by the pandemic in employment and health care was no exception, was really disrupted. So it was difficult to discern what was a trend when the house was on fire. But I would argue we're kind of back to those pre-pandemic drivers, and just want to point out that the two major ones are demographic and economic. Nevada is poised over the next decade to add about 300,000 residents, all things being equal. That will drive considerable demand for healthcare services and thus health workers. Likewise, the population over the age of 65 is projected to grow again over the decade by 120,000 or 26%. Again, all things being equal, an aging population is going to require additional health services and health workers. Also want to point out that as the economy improves and has stabilized, economic growth and the growth of decent paying jobs represents another major driver of demand for healthcare. To take one example from up here in northern Nevada, the Tesla Gigafactory, when all is said and done, is going to add 7,000 plus jobs to the local economy. I checked yesterday, and the average wage is $60 an hour, and most of those positions come with decent comprehensive healthcare coverage. And again, with growth comes additional demand for healthcare. I've listed some other items there just to point out that it's not all economics and demography. Our state's evolving population health needs, growing insurance coverage that continues to happen in the wake of the Affordable Care Act, and other policy measures are also influential in driving additional new demand in the state. When we turn to major health workforce supply trends in Nevada, first, the good news. For about as long as I've been looking at this data, which is a little over 2 decades, we've seen a steady growth in licensees to the state, despite having underdeveloped healthcare education programs as a general rule. That's good. Nevada remains an attractive place for health professionals to live and work, and we see that borne out with the licensure data. But I would caution that a trend I call treading water. Just as we've seen the number of licensees grow in the state, when we adjust for population growth, some of those trends get flattened. So that, and I'll share a little bit of data on that. Some of the trends that concern me the most is that when you adjust for inflation, the actual growth over the past decade for psychiatrists and psychologists, clinical psychologists, has been relatively flat. So while we're again attracting people to come to the state to practice in behavioral health, we're barely keeping up with population growth. A couple of other trends I'd like to point out is just as we have an aging population, we have an aging workforce. And one of my concerns over the next couple of years is that as the economy improves, what we typically see is those older healthcare workers exit the workforce as the retirement portfolios improve and so forth. So let's be mindful that the workforce is a reflection of the broader society, and both are aging disproportionately. Also want to highlight what I refer to as the diversity mismatch between providers and population served. It's a fancy way of saying we need our healthcare workforce to mirror the populations they serve. We have a state, Southern Nevada, for example, where about a quarter of the population, if not more, self-identifies as Hispanic origin. We need more providers across the deck that reflect, again, that sociocultural diversity. I'm not going to steal any of Blaine's thunder, but I'd also want to point out that a trend that we continue to see in the state is what I refer to as the geographic maldistribution of health professionals, a fancy way of saying there's huge rural and urban disparities in access to a wide range of providers. The next couple of slides, I'm going to really move quickly through this. And if you have any additional questions, we can hopefully take them up in the Q&A. But just want to highlight the extent and severity of primary care workforce shortages in the state. This is health professional shortage data that comes from the federal government. What my office has done is we've tried to estimate the percent of population that reside in health professional shortage areas. The darker the blue on this map, the more severe the shortage. But if you just visually look at this, there's very few areas of the state, rural versus urban, north versus south, that are not facing primary care workforce shortages. Our estimate is that close to 7 in 10 Nevadans reside in a primary care shortage areas. And I would also note that 11 of our state's 14 rural and frontier counties are single primary care HPSAs. Another way of saying that is we have about 300,000 folks residing in rural areas, and close to 250,000 are reside in a primary care HPSA. Also, additional data. This is recent data from the Robert Wood Johnson Foundation on their County Health Rankings Project. Wanting just to share with you, just to highlight across the state's 17 counties, what primary care workforce shortages look like. They're not necessarily more severe in rural counties, but the lighter shaded bars in this graph. But when a rural county loses one doc, or they lose one nurse practitioner or one pharmacist, you immediately see the impact of that, as is the case with Lyon County. Another thing that I'd want to point out in this graph, there's only 3 counties in Nevada right now that are above the national average when we look at the ratio of population to a single primary care doc. In a word, a lot of work to be done. The next slide, I want to highlight what the shortages in nursing look like. I do and don't like rankings because they don't necessarily tell policymakers what do you do with the ranking of 45th. We've been stuck between 45 and 51, if the District of Columbia is included, for as long as I've been looking at this number. But I'd like to point out first that in the bottom 10 states in these rankings, 6 of 7 states that surround Nevada are also facing their own workforce shortages. So let's be mindful that we don't want to be producing new nursing graduates only to see them go to states that neighbor us with equally severe shortages. On the next slide, what we've tried to do in my office over the last couple of years is translate those per capita averages, which don't necessarily, point to the work that needs to be done, and looked at, so what is that 7.92 RNs per 1,000 population look compared to the national average? And what we've tried to do is estimate how many additional nurses or providers it would take to meet that national per capita average. I double check and triple check these numbers because I don't believe them sometimes, but our latest estimate says that we need over 3,000 registered nurses just to be average. One of the ones that concerns me the most equally is we need over 5,000 nursing assistants just to be average. So when we think about what we need to do and the direction we need to do, and I think we should aspire to be more than just average. Don't get me wrong there, but there's a generation's worth of work to do to improve these numbers. I now want to quickly go through policy measures that you might consider to address workforce shortages as we approach the 2025 session. For sake of simplicity, I throw these measures into 3 buckets, the first of which I call grow your own, and that's simply increase the number and diversity of health program graduates by increasing the capacity of those healthcare education programs in the first place. More on those in a moment. I think there's also a wide range of measures that we can take to stretch the existing workforce, and that is to say, without adding another worker, what can we do to make allow individuals to practice at the top of their scope, work as team members, and so forth. I think to their credit, the legislature has passed measures, for example, allowing Medicaid to reimburse facilities for community health workers and other very important members of the healthcare team. Again, with the aim of making the most of our existing workforce. And then finally, kind of a residual category of various measures, good, bad, and ugly, which I'll highlight with an example or two. So if we go through, Joseph, the next 3 slides, I'm not going to touch on every one of these, but again, at the heart of Grow Your Own strategies are efforts that we can take as a state to prepare additional individuals, ideally Nevada residents, Nevada students and so forth, for licensure as health professionals. Sometimes this means creating new programs. Sometimes it means expanding programs. Megan and Sarah are going to describe some of the efforts that are also essential to orient kids in the K-12 to prospects in medicine and nursing and other health professions. That's equally part of it. Next slide. Here are some of those examples of stretching the existing healthcare workforce included. And note again, we need incents to practice in team-based care models. We need to increasingly use workers across a wide range of fields practicing at the top of their scope. There's also a couple of telemedicine opportunities here as well. And it's good to see that with the end or the winding down of the pandemic, some of those telemedicine reimbursement provisions, both at the state and federal level, look like they're going to be made permanent going forward. Next slide. The final category, again, kind of good, bad, and ugly, are measures that we can undertake to, again, lure folks to the state of Nevada to practice. The top of my list is always licensure compacts and reciprocity, which I hope this commission and lawmakers will revisit. Nursing, I know, is had a couple of shots at licensure compact. I think social work has been discussed by some of the behavioral health boards as well. So you have a lot of options and measures that you can pursue. And again, going forward, I'm happy to speak to any of those. And I want to highlight what I consider a couple of major success stories. And this is kind of from that first Grow Your Own bucket. In the 2015 session, then Governor Sandoval spearheaded legislation that created the governor's GME grant program. The first awards were made in 2016. And in this and subsequent slides, I'm going to argue they did exactly what they were intended to do. And that is, if you look at 20 years of data on graduate medical education programs, that is residency programs and fellowship programs for physicians that already have their MD or DO degree, we saw a really substantial increase in those programs with the onset of those grants in 2016. Likewise, in the next slide, we also saw a very dramatic increase, a doubling in less than 10 years in the number of physicians in those programs. Good story. And then finally, I would argue we've almost increased the number of grads in those programs with the onset of that GME grant programs. And again, my mantra is build them and they will come. And I would add, build them and they will stay. We're working on an analysis right now over that 10-year period about how many physicians who completed their GME in Nevada stayed in practice. I'm guardedly optimistic that it will confirm what we know, and that is we typically retain 55 to 80% of docs who complete their residency and fellowship training in Nevada. So as we expand those programs, we expand the number of physicians completing, we will retain more physicians. So really good policy measure here. Switching gears a little bit, I want to highlight a couple of important trends in advanced practice clinicians licensed in the state of Nevada going back to 2008, and highlight a couple of factors responsible for this, again, very dramatic growth. If you look at this chart, these are not number of licensees, these are adjusted for population growth. And what we've seen since the passage of Assembly Bill 170 in the 2013 session, a pretty striking and dramatic growth in the number of nurse practitioners in the state. Now, the state's masters in nursing programs have also grown and expanded during this time period. But this is a really good example of a policy measure that did exactly what proponents said it would do, and that would be make Nevada a more attractive place to practice as a nurse practitioner. Also, we've seen some pretty impressive growth in the PAs coming to the state as well. And I think that is due to the creation of the program in Southern Nevada at Toro, and followed by the relatively new program up north at UNR Med for PAs. So really good success stories, combination of grow your own and stretching the existing workforce. I want to close just by highlighting some of what I consider to be health workforce wins. When Packham talks about a win, all I'm trying to say is I believe that each one of these measures here stands to move the needle on addressing provider shortages. At the top of my list, and one I hope to do a similar graph like we did on GME, is I believe the infusion of $20 million into the NSHE nursing programs is going to do exactly what it promised, and that is increase the number of nursing grads that not only complete those programs, but remain in Nevada. My office has done some analysis on the first job of nursing grads from NSHE programs, and we keep upwards of 85 to 90% of those grads. They stay in Nevada, again, build them, and they will come. When I look at, won't call these losses, but figuratively say 2 steps forward and 1 step back, a couple of bills that passed, Assembly Bill 404 and 401, are measures that hold the potential of taking us back unnecessarily. AB 404 is the medical malpractice caps. I think that one remains to be seen what the impact is that on the physician workforce. My only concern is when you raise those caps and make it more expensive for a physician to practice in the state. We've seen historically some out-migration in certain fields like OB-GYN and other areas. At the bottom of the list are a number, again, of items that didn't make it out of committee or out of the House or were vetoed by the governor. And again, I hope that we revisit them because each one of the measures, the bottom 5 there, hold the potential to move the needle on provider shortages or at least complement efforts to expand the state's workforce. So in conclusion, to no surprise, I think there's a good deal of unfinished business when it comes to health workforce development. We saw a number of one-shot appropriations, including that $20 million nursing grant program that we need to consider ways where we can just bake that into state and NSHE budgets. Those dollars will be put to good use and do what they were intended to do. Likewise, or ditto with graduate medical education. And then I've listed some other additional items that warrant your consideration, and happy to speak to any of them. But in the interest of time, I think what I'll try to do is open it up. As I told Joseph in preparing this presentation, we have a number of reports coming out in 2024 that I think would do a good job of informing your work. Even if we don't have these completed, Joseph, I'm more than happy to share some of the preliminary results like we did with a couple of tables that I shared with the commissioners prior to this meeting. So with that, I'm happy to take any questions. And again, appreciate the opportunity to speak with the group this morning.
Thank you, John. That was a lot of information, but a lot of great information. So can't wait to continue to digest it. Anybody have any questions for John? Mr. Kipper.
Hey, good morning. I'm Scott Kipper, and 2 observations. One, the information, John, that you presented, we will share with the Network Adequacy Advisory Committee, which is an organization housed or at least managed by the Division of Insurance that looks at and sets network adequacy standards across the state. And I think the information you presented will be very helpful to this commission as they pursue their work for the balance of this year. The other thing I would like to touch on is that there were some, there was another bill that was passed, AB 398, which changed the way liability insurance it would be created and drafted and implemented. And that also addresses the issues around medical malpractice insurance. So I want to just flag that because we think at the division that that's a significant game changer in not necessarily a good way for physicians and or other healthcare professionals. So I just wanted to tap those 2 points for further consideration. But again, thank you for a very terrific presentation.
Thank you.
Does anybody else have any questions? Wendy.
You're muted, Wendy.
I know. Thank you so much. And Dr. John, wow. I just love every time listening to you and what you bring to the table and what you share and how you can boil it down to digestible topic areas that can be taken on, but it certainly heightens awareness. We continually hear, because I get so much information from national news stuff that comes to me on the shortage, certainly in long-term care, of the clinical staff, the nurses, the nurse practitioners, and of course, CNAs. And I also see an opportunity for us to take some consideration on how the regulatory process actually has an impact and puts barriers up for the continual training and site training of some of our CNAs. So I just want to submit that for future discussion to our group. And maybe we can be helpful and inspire more individuals to go into the field. If we can excite them to becoming frontline caregivers, then they're on a track to moving up through other advanced degrees. And I've witnessed that over the years. So I'm so appreciative of what you presented. Thank you.
Thank you.
Thank you. Does anybody else? Bethany, please.
Thanks so much, Dr. Peckham. Just maybe two questions. One is, in the data that we have around the workforce, many of those clinicians now may also be practicing within the state, but through telehealth means. Do we have an understanding of those that actually are domiciled within the state versus they may be in New York, but licensed here and providing care through telehealth?
Honestly, we don't, but we need that data because I often see historically, if the legislature telehealth being promoted as a savior for addressing workforce shortages and problems, but that presumes there's a provider on the other end of that consultation, be it somebody licensed in Nevada who lives in Nevada or another state. Anecdotally, in speaking with folks that oversaw the then Governor Sisolak's Directive 11 on expanding telehealth providers, we saw a couple of thousand physicians and nurses become licensed in the state who provided largely remote services. They didn't move here. They didn't change where they lived, but at least temporarily they did. And I think that holds promise in what we could continue to do, and that is not rely exclusively on out-of-state providers for those consultations, but being an equal opportunity adopter of that in the short term. So it works both ways. People can also live and be licensed here and do the lion's share of their work in other states. But I think there's an opportunity there.
Thank you.
Does anybody else have any questions?
Can I ask one more?
Yep, go ahead. Sorry.
And then the second question was around sort of the pipeline. So prior to like graduate medical education and in college and other things, in the K through 12 realm, do we have any data or stats around any programs specifically in that arena?
I am not going to steal any of their thunder, but Megan Kamlasi and Sarah Hunt are going to provide you several great examples. So the short answer is yes.
Thank you.
Yep.
Okay, Commissioner Khan, did I see your hand up?
Yes, thank you. I just have a quick question on the GME programs. What is the greatest hindrance to the expansion of those programs?
Dollars.
Just money, not space?
There's a couple of things that remain obstacles. You need dollars to start up these programs. When the UNR Med is right now exploring the rollout of 5 residency and fellowship programs over the next 5 years, the price tag per year on those are typically between $2 and $3 million on the short end, maybe more if you're talking about surgical residency programs. The state also faces the obstacle of most hospitals operating at the cap for what CMS will reimburse hospitals for residency and medical education training. So there's some stuff we can do at the state level that is such as the case with the governor's GME grant programs to start up and launch. But there's a larger issue. It can only be addressed at the federal level through our congressional delegation. It's been increasing the cap on what hospitals are able to receive from CMS to support that. UMC is over the cap. Renown Health is over the cap. So yes, we can add those positions, but at the end of the day, those hospitals will be on the hook for paying those, the salaries of those physicians over. So we've made progress in the last couple of years. CMS is in the process of adding 1,000 additional spots, and I know that both Renown and UMC have taken advantage of those opportunities. And we've added a handful, but even 3 to 5 per year makes a difference. So.
Thank you.
All right, does someone else have any questions? Do I see a
Dr. Curry Winchell.
Oh, okay, perfect.
Yes, thank you, Dr. Packman, for a wonderful presentation. I was just curious, when we talk about the lack of representation, you shared the representation that's in Southern Nevada, but when we look at Northern Nevada, have you been able to identify any spots? Like when I talk about myself, I'm a Black female physician, and overall, I represent less than 3% of physicians in the US. So when we talk about growth, we also have to talk about representation, as you mentioned. And so
Yeah.
have you been able to identify any data, for Northern Nevada? Because in our little small circle, there's about 8 of us that I've been identified, as far as Black physicians in Northern Nevada.
Yeah. I don't have data on the existing workforce, but what I do have a little bit, and I'll share it with Joseph to push out to the group, is statewide and by region, what the last 10 years of graduates look like in terms of sex or gender, as well as self-identified race and ethnicity. I'm guardedly optimistic that we're making progress, but at the risk of stating the obvious, when you go into a dentist's office, you're typically not going to see a person of color. And that's kind of an offhand anecdotal example there, but in other fields and in other practice locations, you see the same story. So I'm optimistic that we are producing a more diverse set of graduates with each passing year in this state. And that's ultimately the long-term solution. But my suspicion is if we were able to get that data of the existing workforce, it would be a different story. How's that? I
agree.
completely
My
dodged that
follow-up.
question.
No, that's okay. And the reason where I was going, and as I'm sure you know, when we talk about, diversity breeds more. And so when the existing workforce is lacking that diversity, often those graduates, especially when I'm working with some of the medical students here at UNR or the residents, if they're not able to see others living in our community and see that kind of solidarity, they're unlikely to stay here as well. So I think it's twofold, where you want to see others that look like you, that are flourishing in their practices, working, as well as we grow that pipeline. Because if you grow that pipeline, I think there's a sector that may not stay only because of the current workforce that we have.
Exactly. Later this afternoon, for any of you attending the UNR Med commencement up north, what you will see walk across that stage is a majority of our graduates are female, and a good number of them represent every walk of life in the state. So I'm always encouraged when I see who's entering the field each year, and the same will be the case later this afternoon.
Okay, great. Does anybody else have any questions? Seeing none, I just have one, John. So are there some best practices with apprenticeships? So I want to give you an example. So in Clark County, we have a paramedic shortage like no tomorrow. And one of the things we have done is invested in subsidizing that person to go to school. And in Mesquite is where we've done it, and we have had the same 10 people the entire time that are going through the process, and we pay them to just go to school. Have we thought about doing that? Have we thought at the state level and the local level to, love to hate HRs, right? Because it's an act of Congress to get a job with any government agency. So have we thought about the apprenticeships, putting them in the state? The state always has tons of openings. The county always has tons of openings. Have we thought about doing as we did with teachers back in the day, where we did the student teaching, where you did it and you were getting paid to do it? Because I find that more and more people are struggling. You either got to give up your services to go to school, or you can't afford to live and go to school and take care of your family. So we really thought about maybe maximizing some of those workforce dollars and doing something different. Is somebody doing a better job than we are?
The short answer to that, I think Blaine and Pat Kelly are going to address it, is we have a great example, and that's the nurse apprenticeship program. I love those programs because they're kind of premised on the radical idea that students might want to earn a living wage while they're getting educated. And I would argue that that's one more factor that's going to lead to their staying in that facility, if not the state. So there is some good news on that front.
Okay, great. So seeing no other questions, John, thank you for your presentation. We'll now go to item number 7, which is a presentation on hospital-based workforce challenges and policy considerations. So we'll invite Patrick Kelly and Blaine Osborne.
Hey, good morning, all. I'm Blaine Osborne, president of the Nevada Rural Hospital Partners. Very briefly, NRHP is a consortium of the 13 critical access hospitals in the state of Nevada.
Good morning. My name's Patrick Kelly. I'm the CEO of the Nevada Hospital Association, and we're just thrilled to have the opportunity to present here today. Hopefully everybody can see our slides. Just want to start off with briefly, here's what we want to talk about. We're only going to go through a few healthcare facts because Dr. Packham did a fantastic job. We want to talk about some specific workforce needs, physicians, nurses, and other healthcare occupations. When I go around the state and talk to CEOs, the big 3 that they always talk about are the need for physicians, nurses, and CNAs. That's a big area that everybody agrees on there's a need, but there's also a need for a lot of other healthcare professionals that we'll talk about. And then we were told to try to emphasize best practices and ideas that existed in other states. So we're going to take that on. You know, Dr. Packham mentioned this for a minute, but I think this is the most powerful statistic and could guide your work. We have 3.2 million people. 2.2 million live in federally designated primary medical care health professional shortage areas. So in primary care, we're short for 2.2 million people. 2.8 million people reside in a federally designated mental health HPSA. So we have so many needs out there. And so I'm glad that we're focusing on workforce and trying to find some practical solutions.
And the point I wanted to make on this slide is that it's not just emergency medicine. It's not just primary care and family medicine. It is all of the specialties as well. We have significant shortages across, as you can see, almost nearly every physician specialty in the state. And in your exhibits, you have a wonderful 2-pager, figure 4 and 5, that really shows line by line those specialties and what numbers are needed, particularly in each of the rural counties. And you can see in our rural counties, many of these specialties are simply non-existent. What that means is for many of those patients, they're having to take on very long commutes and travel times to either Reno or Las Vegas, or in a lot of cases over to Salt Lake City or over to the Bay Area in California in order to get that care.
And also keep in mind that in a lot of our urban areas too, we have incredible shortages. So I met with a group of physicians, CEOs, and I said, look, I'm going to make this presentation. I want to kind of show this group the diversity of the need for physicians. And you can see we need physicians in all areas. This is not a scientific study by any measure. I just want to give you a taste of the diversity. Dr. Packham put in his materials some charts that provide a good analysis of the need for specific practitioners. And you know that's what you should rely on. But to give you an idea, we need a little bit of everything and a lot of some things.
So the big idea here is we really need to increase our in-state graduate medical education, residency, and fellowship programs. Now, the legislature began to take a swing at this in the last legislative session, passing Senate Bill 350. I would encourage respectfully the commission to request Brian Mitchell from the Office of Science, Innovation, and Technology to provide a status update on the implementation of Senate Bill 350. Mr. Mitchell spoke in the March Interim Health Committee meeting and gave some updates on that. But one of the bills that didn't pass last legislative session was Senate Bill 369, which I thought was a very innovative way to try to help fund some of these residency and fellowship programs. It was a suggestion to offer tax credits against the modified business tax for employers who are willing to make donations to these types of residency and fellowship programs. Those are the kind of innovative ideas that we need to be exploring in order to increase these programs.
Another idea for your consideration is that we have a lot of loan programs for professionals to try to encourage them to stay and work in different parts of the state. But one of the things that you might consider doing an add-on is offering an incentive for students who attend our medical schools and then receive their GME in Nevada. Because as Dr. Packham just said, up to 80% of the students who go to school in Nevada and then do their GME in Nevada tend to stay in Nevada. And so we could be encouraging that by providing a little extra incentive for those students to choose to take their GME in state. Because the problem we run into is once they leave and go to a GME program out of state, it's very difficult to recruit them back in. And this might avoid some of that, and we could maybe have a higher retention rate. Just wanted to now go to nursing. It's a huge issue for everybody. Just wanted to, people say, well, if you just paid nurses a little bit more, we're actually one of the highest paying states in the country. You can see that the annual mean wage in last year in 2023 was $97,700. We're probably up around $100,000 right now. And for LPNs, it's $66,580. There was a report about a year ago that showed that when adjusted for the cost of living, Nevada's RN wages were the 6th highest in the nation. So we really are up there in terms of the compensation. One stat that I want to share with you that I think is really telling, and that is 40% of Nevada's RN licenses are held by nurses with an out-of-state address. Now, there's no doubt that there's nurses in Truckee who are working in Reno. Don't question that, but 40% is a huge number of licenses. So how could that number be? Dr. Packham just mentioned it a minute ago about telehealth, and that's one response. But what happened was during the pandemic, we brought in thousands of nurses because there was just such a demand. And when those nurses came in, whether they worked one day or they worked 3 months or 6 months, they had to get a license. And that license continues for 2 years. So I'm a little worried that we're going to start to see a decrease in the number of RN licenses, but I'm also concerned that some of them may continue to renew this. So when we look at national stats and where we fall in that, I think we have to keep in mind that 40% of our nurses do not have an in-state address. And I think that is just a significant number.
One of the significant worries that I have for the state of Nevada is in long-term care, and I think this is a national worry across the country. In 2019, the legislature passed a bill, AB 122, that did a feasibility study of combined licenses for assisted living facilities, adult day, and respite care programs in the state. And I provided the link. I would really encourage the committee to take a look at that. It's a fabulous report with a lot of suggestions. You'll be reading for quite a while. I think it's about 300 pages long. A lot of really great work that still needs to be done there for the state of Nevada. And there was a big announcement that CMS made just about 3 weeks ago, April 22nd, regarding nurse staffing ratios. And CMS is considering finalizing a rule issuing minimum staffing standards for long-term care facilities. This is going to be a real worry and probably a real problem in the state of Nevada, as those nurse staffing ratios are suggested to include an on-site registered nurse 24/7 in the skilled nursing facilities. Currently, most of our skilled nursing facilities across the state cannot be in compliance with those mandates. And so as we're looking, if this rule does go into effect and is finalized, that's going to put several of the long-term cares and skilled nursing facilities in a very bad place to make some very tough decisions in the future. I know a lot of our rural hospitals that operate distinct part skilled nursing facilities are considering eliminating their LPN positions altogether if they have to only have RNs in order to be able to meet these mandates. So very concerned with that. And we're going to touch a little bit more on CNA programs later in our slides. There are some other very cool ideas and innovative programs being talked about and being implemented. One of the ones is international nurses. There's a group in the state called the International Healthcare Professional Bridge Program that is looking at bringing in international nurses. These are nurses that have to be over the age of 21. They have to be graduated from an accredited nursing program. They have to maintain a current license in their other country. They need to have a minimum number of years of experience, and they have to have certain English proficiencies. And that group is looking to do partnerships with hospitals. They're looking to get support to help bring these nurses to the state of Nevada and get them enrolled in those programs. We also, obviously, I think many of you are probably familiar with the Nurse Licensure Compact. This has been a proposal that has been discussed in, I don't know, 8 out of the last 10 legislative sessions or something like that. And currently, as of January of this year, we have 41 states who have joined the Nurse Licensure Compact. Nevada is not one of them, and Nevada would certainly benefit from being a part of that compact. Last session, we saw some bipartisan support for the compact, but unfortunately, it still died. And then I have a wonderful slide on the nursing apprenticeship program that we're going to get to here. If you're not familiar with the nursing apprenticeship program, this started in March of 22 with a allocation from the Interim Finance Committee and the support of DHHS, which has equaled about $11 million now over 2 years. And what we're doing is helping reimburse students while they are in their nursing programs to get that critical work experience in hospitals and in long-term care facilities. So just in 2 years, we've had 735 nursing students participate in the nurse apprenticeship program. Of those, 222 have been directly hired or retained from the program. And we have 36 participating facilities. Those are made up of nonprofit hospitals and freestanding and skilled nursing facilities in the state. And you can see the amount of dollars that have gone towards that. And I'll just give a shout out to your executive director, Mr. Filippi, who actually helped implement this program with us in March of 22.
A couple other ideas to think about is when it comes to our nursing schools, we need to increase the number of slots that are available. We know that each year that there are qualified students who want to become nurses, they apply for nursing school, and they do not get into nursing school. And so it seems a shame when we have such shortages that we're turning students away. So an idea is to increase the size of classes. There was a bill last year that allowed class size to increase from 8 to 12. That is something that occurs in a few other states. And also to allow experienced nurses to teach or proctor students in a clinical setting. I understand, and I've talked to the nursing folks, that there are certain demands and they have concerns, but I think we have to relook at the model of how we're delivering nursing education, and we might be able to then increase the size of classes. We're also seeing the development of alternative nursing schools, and for those of you living in Southern Nevada, you probably have seen billboards up for Galen College. This is an effort by HCA to increase the number of nurses in the community. And what's really interesting about this program is that they are going to try to target older students. So people who are looking for a second career, maybe in their late 20s or 30s, having them go through and receive an ASN degree. So I think that's a trend that's worth following. And then also we should consider doing some bridge programs. So we have a lot of military medics in this state. So how could we develop a program to get them from a military medic, give them a little bit of credit, and go into an RN program? Now, these programs have existed before, but I think if we really concentrated on trying to put together a program where people in the military all over the country go, this is the easiest one for us to use, that we can access it easily, we can start taking some of the classes while we're still in the military, and then do our clinical settings in Nevada, because I think once they come to Nevada, the to RN bridge programs, another idea, and CNA to an LPN bridge program is an idea. One of the things we find out that the reason CNAs quit is because after a while, there's nowhere to go. There's no way for them to advance. And if we had a CNA to LPN bridge program, that might help retain people and also put more people into the nursing area.
And not just add to that too, in light of these proposed mandates on nurse staffing ratios, we probably need to start looking at considering some LPN to RN bridge programs as well. Also, just wanted to kind of let you know a little bit about the current loan reimbursement programs. Unfortunately, loan reimbursement is not unique to the state of Nevada. This is something we're competing with every other state in the country. Support we can continue to provide for those two loan reimbursement programs is going to be critical.
If you want to see something that's really cool, new, and innovative, it's virtual nursing. And this is a situation where a nurse comes on the screen of a patient sitting in their hospital bed and can communicate with the patient. The nurse is at a remote location. They have all the data related to the patient, all the records, and they can go in, and if there's a call light, answer the call light, just check in on the patient if no one's been able to get in to check them because the other nurses have been busy. And this has been a really great program. As a matter of fact, what I like about it is the patient satisfaction scores go up dramatically and the nurse satisfaction scores go up dramatically because it helps the nurses on the floor so that they're not running constantly from room to room. You have a very experienced nurse doing it. And what's neat about this also is that you can take older, experienced nurses who find it difficult to work on the floor all day and put them in this position so that they can check on things. They can also be mentors to younger nurses who might be experiencing some difficulty or seeing a type of patient they've never seen before. And I think this has tremendous possibilities. There are a few facilities that are working on it. Opportunity to facilitate that growth. And I can tell you that Dignity Hospitals is a leader in this, and Commissioner Bunin probably can tell you a whole lot more about it than I. But I just think that's something that we should be looking at.
Another really interesting idea that we had proposed from one of our member hospital CEOs was for some more collaboration within the NICHE system for nursing student programs. And it'd be really neat if we had some kind of pool of applicants in which students can apply to nursing programs, not individually, but as a whole, so that we're ensuring we're maximizing all of those slots in any given year for nursing students. CNA programs, I think Commissioner Simmons said it really well earlier. If we could create programs similar to the nursing apprenticeship programs, which is for RN students, if we could do that with CNAs, that would go a very long way, I think, in providing some extra support for things like travel, for things like living and salary allowances, for them to be able to take on some of these CNA programs.
So I just wanted to share with you some of the health occupation needs. Once again, this is not a scientific study. It was just an opportunity to ask CEOs, what are they looking for? Techs are in serious demand. And I think we have to look at where the tech programs are and more importantly, where they're not, and then fill in the gaps because there's some areas of the state that are really experiencing difficulty finding techs. And I know in the rural community, we're seeing problems with radiology techs and lab techs in particular.
One of the things I'd really encourage the commission to do or to work on during your deliberations is considering creating an inventory of the programs in the state of Nevada. One of the things we saw kind of along the lines of what Dr. Curry-Winchell was speaking about is several of the certification programs may be available in Southern Nevada, but we don't have the same opportunities in Northern Nevada. It'd be really great to consider the location of these programs when we're looking at what is in existence.
Blaine and Pat, I think we're still seeing slide 14, at least on my end. Are you able to move the slides forward?
Well, ours shows that we're on slide 17 and it's showing.
Is it anyone else having this problem? No, okay, just me. Never mind. Please continue.
Okay.
I was right. I didn't turn it myself. You're good, Joseph.
Okay. The other point we wanted to talk about is there's a really neat program that other states have started to implement or considering, which is a Health Careers Academy. This is a special school where high school students can attend and receive college credits specific to healthcare professions to help ease their entry into these healthcare facilities in the state.
Alabama just passed a law, and it was just passed and signed into law just in the last couple of weeks. And they're going to start a tuition-free public high school focusing on health careers. And so that, I think, something that this commission might want to watch and see how that develops. And if you're looking for a really different idea, I'm going to throw out this idea about virtual reality. There's been a group of us who've been exploring the possibility of developing a virtual healthcare facility that students can go into a classroom, put on a set of goggles, and just go through a healthcare facility virtually and observe the different jobs that are available. We think that it would be a very attractive, because even if a student wasn't particularly interested in the healthcare career, everybody's going to want to put on the virtual glasses and go in and do this. And in addition, I think it provides the diversity that Dr. BCW was talking about, because there are a lot of people in this state who grew up in communities where they don't know anybody who works in a hospital. And they think that the only jobs that are available are doctors and nurses, whereas we have all these demands for techs and different types of people, but they could explore those opportunities virtually. And, this is something that we could just provide on the internet that any school in the country or the world could download to go through. And then I think healthcare facilities could help support the purchase of the goggles for the virtual reality experience for the schools in their communities. So that one, we would like to move forward with it, but like everything else, it's funding. If anybody on the call knows of national we've identified a production company in Las Vegas who says they can put this all together for us. So it would really be a neat opportunity. So we're kind of at the end now. We'll take questions. Blaine will take the hard questions. I'll take the easy questions.
Okay, great. Thank you for that presentation. Andrea Peterson, you have a question?
Yeah, I do. Thank you. I'm wondering if you can speak to some of the concerns that have been brought up in the past with the nurse licensure compact. Because I know you mentioned it's been brought up several different sessions.
Sure. I think the big concern, the big opposition we've seen to it in the legislature revolves around the nursing unions in the state. I think there were several really neat ideas and compromises that were proposed last legislative session to address those. I think those probably need to continue to be on the table. Things like ensuring that any of those nurses coming to the state under the compact have the opportunity to sit with those union reps to learn about the benefits of union representation, those types of things, to ensure that facilities aren't able to get around some of the collective bargaining or those types of concerns when utilizing compact nurses.
But I just want to point out that a lot of states have nurses unions that are part of the compact. The other thing that you hear all the time is that this compact is a union busting bill. And it is not, because they always worry about nurses being brought in during a strike. But under federal law, the union has to give the hospital 10 days notice of the strike. So there's plenty of time to bring them in, whether or not they come in under the compact or not. So I just don't think that's a valid argument, but I just wanted you to be aware that that is one of the arguments made.
Okay, thank you. That's helpful.
Okay, Walter.
Yes, thank you. And I'm sorry I'm not on camera. My bandwidth is low and it tells me to cut off my camera. So that's why I'm doing that. But my question is on the LPNs in our state. And my understanding was there are challenges with recruiting or hiring LPNs because of the board situation. Can somebody educate me on what the board, what licensure board that the LPNs fall under?
Mr. Davis, I believe it's the State Board of Nursing would be the authority over LPNs.
Okay, because and when we talked about, because we were interested in hiring LPNs in our practices, and I understood it was very difficult to do, and there's a conflict, some type of conflict. So if there's not, then I just want to understand the appropriateness of, where to go to understanding creating a LPN program within our state.
I'm not familiar.
Go ahead, Dave. Sorry,
Oh,
Blaine, go
sorry.
ahead.
I was just gonna say, I'm not familiar with any specific concerns right now with LPNs getting licensed in the state, but I would refer you to the executive director of the Board of Nursing, Kathy Denauer, who may or may not be on this call right now and could probably speak more with you on that.
Mr. Davis, this is Marilyn. We can follow up to ensure that we direct you in the right person as well. Joseph is phenomenal, but I'll help get you that correct information.
I appreciate it. Thank you.
Okay. Bethany.
Thank you again for a great presentation. Just want to come back to the virtual nursing that you guys talked about, and it sounded like, and I'm specifically now asking for the rural environment, whether or not bandwidth in terms of broadband and some of the technology infrastructure, do you feel like that is a viable option in those communities, and or is that something that would need additional support specifically? And if so, what might that look like?
Sure, I think it's a great point. It's definitely something to be considered and tested, but I think we can get around those issues. I think most of the communities now, particularly the hospitals and the schools, have appropriate bandwidth for those types of devices. And so I think if we're able to get a program stood up like that, I don't believe that would be a significant barrier.
Okay, Andrea.
Yeah, sorry, just a quick question with the virtual nursing. I would just ask, are there any national organizations that can endorse that as a standard of care? Just making sure that we are meeting standards of care.
I know that there are organizations, national organizations that are very involved in, as I said, Dignity Healthcare is involved in that. And I think it's operating currently in Southern Nevada on a limited note. Okay, off on that. But HCA is also looking at it, and some of the other national companies. So, these are nurses who are licensed in the state who are delivering care virtually.
Thank you. Okay, I have, let's see, Jacqueline. Jalen, is that what it is? Sorry.
Yes. Just to clarify, we in Southern Nevada, we don't have virtual nursing yet. We have virtual sitters that are like safety sitters. Dignity Health does have a program, and our partners in Arizona are rolling out the virtual nursing programs. There's a lot of promise, really exciting to think about the benefits of virtual nursing. I just attended a nursing leadership conference where that was a high focus. But just to clarify, it's not, the virtual nursing piece is not here yet.
Okay, great. Thank you. Does anybody else have any questions? All right. Thank you so much for your presentation, and I'm sure there'll be tons of follow-up questions. Just running out of time. So,
Okay, thank you very much.
Thank you. So, Joseph, I'm going to move a couple of things out of order. I do have a hard stop at 11. My event is starting without me. I can no longer multitask. So, I'd like to go to item number 10 and ask the commission members if there's any items that you would like for future meetings. If you could just email those so that Dr. Khan has the ability to go through them. Joseph, you can email them to Joseph of things that you would like to see, and then we'll do our best to ensure that they get on future agendas. And if you have a contact person, even better, so we would know where to start. So if you could do that, that would be kind of some direction for item 10. Item 11, is the possible action, discussion, and approval of amended commission bylaws. This is something that does need a quorum and does need a vote, correct, Joseph?
Yes, this is Joseph for the record. If members could just, the bylaws have been included in your packets that have been sent to you. If you are able to take a look at those, if you have any questions or issues with the bylaws, now would be the time to briefly discuss that. And then we just need a majority vote on the approval of those revised bylaws.
So I didn't see anything that was out of the ordinary, and actually I think it's pretty cleaned up. Does anybody else on the commission have any concerns or questions with any of the bylaws? If not, I'd entertain a motion and a second. So I'm willing to make the motion to approve the bylaws. A second.
I'll second
Walter
it.
Davis seconds.
Thank you. Bethany Sexton has seconded. Any discussion on that item? Seeing none, all those in favor, please say aye.
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 Any opposition? And that motion carries unanimously. Item number 12, Joseph, is that, are you just going to send out some Google Calendar to see what the dates work best for everybody?
Thank you. Yeah, Joseph Filippi for the record. So I have sent out just a request for the next month's meeting in June. It tentatively looks like June 21st is the date that best works for the majority of commissioners. But happy to continue to work with any members regarding their availability for next month's meeting. So yeah, we don't have to officially discuss all the future meeting dates at this time. I know that there's a time crunch today, so if you guys can just please let me know what date works for June, that would be helpful. And then if there is a day and time of the month that we want to just set going forward, as far as like, the second Monday of every month or something like that, just whatever day works for the majority of the members, we can set that going forward. But yeah, I'm happy to work with you offline on future meeting dates.
So Joseph, I'm going to speak for myself, and I would bet everybody else on this board. It's best if there's just like the third Thursday of the month or whatever, and that we know that we got to allocate 3 hours. So if everybody could send the day of the week, that's the best, and we can look at a majority with Dr. Khan. I just know for myself that, and everybody else on here, there's so many meetings that you just pick a day of the week, and we'll all do our best to get there. So.
Thank you.
Okay, so I apologize. I do have to get off, but Joseph is going to continue with the other two presentations and then the public comment. So do you need anything else from me, Joseph?
No, Commissioner Kirkpatrick, thank you so much for your time today and good luck with your event.
And thank you, and you're a great executive director, and thanks for all the information. So appreciate you. Okay,
Thank you.
thanks.
All right. So I know a couple other members had to drop off early. So just really quickly, if we can make sure we still have a majority of members present, you could please just let me know if you're here today. Jalen Behunin.
Here.
Bio Curry Winchell had to drop off. Walter Davis.
Present.
Flo Khan.
Here, present.
Andrea Peterson.
Here.
And Bethany Sexton.
Here.
Perfect. That makes 5. That's a majority. We can continue. So next on our agenda today, we have with us agenda item number 8, a presentation on healthcare workforce pipeline development working group and policy recommendations. Today we have Megan Kamlasi, the Associate Director with the Center for Public Health Excellence of the School of Public Health with the University of Nevada, Reno, UNR. We have about 15 minutes allotted for this presentation, including questions and answers. So Megan, if you're ready to go, we can get started.
Thank you so much, Joseph. Can you all hear me?
Yes.
Great. Okay, I'm going to go ahead and share my screen. Appreciate the invitation to present to you all today. I'm Megan Komlassi. I'm the Director of Public Affairs and Policy at the UNR School of Public Health, and I work closely with the state's Division of Public and Behavioral Health on a number of statewide public health initiatives, and I'm excited to speak to you today about two of those, and both relate to healthcare workforce and access to care in Nevada. The first is the Nevada Healthcare Workforce and Pipeline Development Work Group. When I initially started in this role, one of the things we needed to work on was the public health workforce and take a look at it statewide and holistically. And as we started thinking about what we would do and who we would talk to, it clearly became apparent that both the primary care and behavioral health care workforces were in need of attention as well. And that if we were talking to some of the folks to work on the public health workforce, it would involve a lot of the same people and same conversations as those if we were talking about primary care and behavioral health. So rather than have various conversations, we tried to bring people together to reduce duplication and enhance efficiency and pursue workforce conversations related to public health, behavioral health, and primary care. So the work group we established was really to address a lot of the challenges that we've heard about this morning. There's workforce shortages in nearly every type of health professional. We see shortages that are more acute in certain professions in certain areas of the state. We also see a lack of diversity in the healthcare workforce. And we knew that the workforce challenges that Nevada faces isn't for lack of effort. As long as I've been working in this field, it's been a chronic issue in Nevada. We know that there are various governmental agencies and community organizations and businesses working to improve the healthcare workforce pipeline and workforce development. But largely these efforts are siloed. They're siloed between regions, between industries, between stages of the pipeline, which really reduces the efficiency as entities are, don't know what's going on and maybe don't use existing resources or are working on solutions that already exist in other parts of the state that they're not aware of, or as we're competing for limited funding. This is a small state, and we saw that there were a lot of entities working in these areas and competing rather than working together. So with funding from DPBH and in collaboration with Andrea Gregg, the CEO of High Sierra AHEC, we developed this workforce work group. The work group aimed to improve, grow, and diversify the public health, behavioral health, and primary care workforces and workforce pipelines in the state to ensure that we have a workforce capable of meeting current and future healthcare needs. And our primary objectives were to identify and map workforce pipeline development initiatives in K-12 education, higher education, and the current workforce. So to some of the questions commissioners had previously, do we know what exists in Nevada in terms of healthcare workforce development? We may not know everything that exists, but we have tried to pull together a pretty solid resource of a lot of what exists. And that is the first step. What do we have? Where are the gaps? And how do we address it? So the second objective of this group was to enhance education and awareness, to connect non-traditional partners, to identify opportunities for collaboration, and then maximize those limited resources that we're all competing for. But really the idea was, if we don't know what's going on in the state, how do we build on it? How do we identify gaps? And how do we move forward? So we needed to bring people together to talk about what exists and what we could do to make it better. And then the third objective was to create and implement workforce pipeline development plans for our three subsectors: public health, behavioral health, and primary care. So the entire initiative was a lot of information sharing. It was a lot of bringing people together, identifying opportunities, and then creating these plans to do something about it. And two attributes really made the work group unique. The first is that our members included stakeholders from all of the sectors listed on this slide. And the thinking was that we could do more to improve healthcare workforce development by bringing together partners from all of these sectors throughout the workforce pipeline, so that we could break down break down the silos that exist, share information, and collaborate, build on what exists rather than competing. Our initial advisory committee included around 20 representatives from these different sectors. And then as we expanded to have additional members and subcommittees on each subsector, we ended up with anywhere from 45 to 60 members, depending on the meeting. The second thing that made the group unique is that we focused on the entire pipeline, everything from introducing and engaging youth in K-12 system or the K-12 like age range to preparing and training the future workforce through vocational training and higher ed, and then to looking at training and career advancement opportunities and ways to retain the current workforce, and identifying opportunities to improve the workforce and workforce development at each stage of this pipeline. And so this graphic shows various opportunities both to recruit the future workforce, and the arrows show how organizations or entities working at different stages of the workforce pipeline can and should interact to create a strong pipeline. So even, you know, if you're working in the industry and you're in nursing, there's an opportunity for nurses or the nursing association or board or hospitals to go out and, you know, meet with youth in K-12 schools to, you know, introduce them to nursing as a career, or maybe to, you know, the CNA, LPN, RN pipeline. There's opportunities for engagement at each stage. And so it really is a circular interaction should be happening if we want to develop a strong pipeline system. Yes, so we'll all come back and talk about some of the entities that exist in each of these stages in a minute. But that was kind of our approach. And the work group ended up meeting monthly for almost 2 years, and we accomplished a lot while we were meeting. Like I said, we engaged in information and resource sharing. We heard presentations from work group members and folks outside the work group to better understand who was doing what in the state. And with that information and additional research, we created workforce development asset maps for each public health, behavioral health, and primary care. And this is something that I shared with Joseph, and hopefully he has shared with you. But essentially, these are documents that are organized by the pipeline. So K-12, vocational training and higher ed, and current workforce. This is for the behavioral health workforce. And just to give you a little glimpse of what it looks like. So if we're talking about career outreach and exploration, we're talking about youth in the K-12 kind of age range. We also have academic success, college and career readiness, and we can see which organizations are doing what in this area. I think Pat and Lane mentioned a healthcare careers academy. Right now, Nevada Department of Education has a career and technical education program, and it has a health emphasis. And this is a program that doesn't exist in every high school, but it exists in a number of high schools. And it's an opportunity to get those already science-minded, you know, youth in high school interested in healthcare careers. And so if we're going to build something like an academy, let's look at what exists. Let's see what works with career and technical education. Let's figure out whether we build out at current schools or whether we expand to other schools. But the idea is we can use this asset map as a place to start to understand what exists. And we haven't updated these for probably a year at this point, but what exists in the state, where potential partners are, how we build on what exists, how we work with people who have already established programs to expand them broader, or to replicate in other places. So this is one of the outcomes of the work group, and I think a great resource as you all are moving forward with your work. And then finally, we ended up creating 3 subcommittees, one each for public health, behavioral health, and primary care. The subcommittees met to understand the rural issues in each of their subsectors, and develop essentially strategic workforce development plans where they outlined goals, objectives, and strategies to address those issues. And I am not going to review those today just because of time, but have provided the plans to Joseph as well. And am happy to answer questions or talk about them. At this point, the work group is not meeting anymore. We had limited funding and capacity, and so we did as much work as we could, and then ended up spinning off our subcommittees and their work to different partners. So the primary care subcommittee work is now living with the statewide area health education centers, which is administered through the UNR School of Medicine. My team's working on implementing the public health plan. And then Dr. Sarah Hunt, who you'll hear from next, is working on a lot of the behavioral health pieces through Be Here Nevada. So we're continuing to work to implement the plans. I still think very good sources of recommendations for you all. I think the asset maps could be helpful resources as well, and happy to provide updates on kind of what we've done in terms of implementation at another time if that's of interest. So that's the Nevada Healthcare Workforce and Pipeline Development Work Group in 5 minutes or less. And our next topic is the second initiative that we're going to talk about, and it is Nevada's first ever state health improvement plan. This is a statewide document also funded by the Division of Public and Behavioral Health. It builds on a 2022 assessment of health needs throughout the state, and it takes those needs and identifies priorities to focus on over the next 5 years and creates a systematic plan to address them by making progress on specific goals and objectives. And the idea is that this plan can be used as a roadmap for DPBH, for DHHS, for community partners, for other state and local agencies, for anybody who's interested in moving the needle on issues related to healthcare in Nevada to improve the health of Nevadans. And so in addition to identifying priorities, the plan provides guidance to all of our different state and local partners, community organizations, et cetera, on key issues to improve health. It can be a tool to help create or refine priorities, to prioritize resources, or to develop and implement projects or programs or policies. And it also provides a foundation from which we can take collective action. And the idea in developing this and identifying these key priorities and goals and objectives is that we can accomplish more if we're all moving in a similar direction rather than if we're all going off in different directions. So these are the plan's high-level priorities. And as you can see, there's significant overlap between the Patient Protection Commission's charge and the areas of access to care, mental health and substance use, and public health infrastructure. And these are all very broad priorities, and the State Health Improvement Plan narrows the focus to a few specific issues within each priority, and then identifies some goals and objectives for each area of focus. So I've included in this slide deck the goals and objectives that relate to the Commission's charges. And if you're interested in additional background information or context about the issues, or some information about existing efforts to address some of these issues, I would encourage you to review the full State Health Improvement Plan, which I also provided the link to. But just to kind of run through a few of them quickly. Access to healthcare focused on access to oral health, as well as the behavioral health workforce and healthcare workforce. The various groups that put this plan together considered a number of issues that affect access to care, but really so much of the challenge getting care in Nevada comes down to the fact that we don't have enough providers, which John so eloquently described earlier. Access to oral health care is also an issue, especially among certain groups and in rural Nevada. And oral health influences our health in a variety of ways. And tooth decay is especially problematic for children. It influences their health and development. And we see access to care issues, but especially in underserved areas and especially in very young children. So that's why we included oral health as well. Want to note that we've seen a lot of momentum in the areas of workforce development, at least in recent years in the legislative environment, but there's still so much to do. And as I mentioned, based on the last part of my presentation, or the first part of my presentation, is just that so much is happening, but so much happens in silos, and we need to be working together. So I'm not going to review these, but put some highlights in these slides of issues that you might want to look at just based on the PPC's charge here and looking at access to care and healthcare workforce. A lot of goals and objectives related to behavioral health workforce. A lot of these also align with and were informed by the plans that the Nevada Healthcare Workforce and Pipeline Development Work Group created. So there's a lot of alignment there. I think you'll also see a lot of alignment with what Dr. Packham discussed, as well as what Dr. Hunt will discuss later. So more behavioral health workforce goal, same goal, more objectives, healthcare workforce, lots of things that relate to what you're working on. Mental health and substance use were also two of the top issues that the 2022 state health assessment identified. And so we know that there's a huge need in these areas as well. There's also a ton happening in Nevada. And so to narrow the focus for the state health improvement plan, the groups that focused on these issues established some criteria so that we could really focus our efforts to have the most impact. So all of these issues, the subtopics that you see, have a statewide impact or the potential to be expanded statewide. They involve major systems change. They require state resources, and they're being addressed through collaboration of various partners. And I won't go into all of the areas of focus here, but again, if you're interested in background information and context, there's a lot of narrative in the plan that helps you understand what the issues are and what could be done to improve it. Again, highlighted some objectives related to improving these areas. For example, in the children's behavioral health portion, access to workforce is huge. And just going back to the work group, one of our work group members represented the Clark County DA's office. And just to note kind of the connection between children's behavioral health workforce and this plan. And she came because they were having trouble getting the young, like the very vulnerable young people they worked with in the Clark County DA's office, behavioral health care. And she traced that challenge back to workforce. And she wanted to be part of any initiative that was aiming to improve the behavioral health workforce because those issues were so significant. So we all need to work together. This affects so many of us. It's not just healthcare or behavioral health. It's system-wide. Another piece, looking at funding. I mean, we heard time and again in doing this that we need to increase the amount of funds that go to behavioral health services. I'm sure you guys will talk about increasing Medicaid reimbursement, but it's not about reportioning the pie. It's about making the pie bigger so we have more funding going to address these things. And then finally, public health infrastructure. This may be something that you're interested in considering. The field of public health essentially serves a critical role in keeping people healthy, but it's often invisible. And it's different from the individual health care we receive in a doctor's office or a hospital because it's focused on keeping entire communities healthy and safe. Yes. Doing things like preventing and controlling the spread of infections and infectious diseases, ensuring the water we drink is clean and the food we get at restaurants doesn't make us sick. And access to public health services is equally important to access to healthcare from clinical providers. And in fact, if the communities are healthier, they seek less care from clinical providers. And so something to consider as you're thinking about access to care, looking at how we provide access to public health services, funding public health services. Many of the public health services that are provided in the state are delivered by the public health workforce. They cannot be delivered without the public health workforce, and there are significant shortages and challenges related to public health workforce as much as there are in the clinical and individual health workforce. And so also included a few suggestions here related to funding public health, providing flexible non-categorical funding. Made some progress on this during the 2023 legislative session with SB 118, which provided $15 million in flexible non-categorical funding to essentially address communities' most pressing public health needs. But it was one-shot funding, it's not ongoing. And so we really want to create a system where, public health departments and authorities are able to respond to whatever crisis is happening and able to prepare for whatever crisis may come in the future so that we can keep people happier and healthier moving forward. So a few more recommendations there. I know that was a lot of information and not a lot of time. Essentially, at this point, related to the State Health Improvement Plan, we're working on developing action plans for each objective, which will be compiled into a comprehensive implementation plan. And we're working with organizations throughout the state to sort of highlight the work that they're doing to move the needle on all of these objectives. And we'll look at the plan annually to update it. I hope that the PPC will be able to take a look at the goals and objectives in the State Health Improvement Plan and potentially align some of what you're doing with what we're trying to do, because the idea is if we're all moving in the same or a similar direction, we can have more collective, we can make more progress collectively than we could individually. So thank you for your time. I'm happy to answer any questions and or provide additional information outside of this meeting.
Thank you, Megan. Really appreciate that comprehensive presentation. A lot to fit in there, but a lot of important work to share. Commissioners, at this time, if you have any questions, feel free to ask Megan. Bethany, go ahead.
Hi, Megan. Thanks so much for all that background, and sorry about the herding of cats because it's a lot. I completely appreciate the idea that when we do more in alignment, it actually has a multiplicative effect. And so I guess I would just ask you more pointedly, out of all of those areas that you've had purview to is, it's really hard to distill it down to sort of one thing. But if you were to say to this commission, what would be an action that we could take that you feel like would be most impactful kind of across some of those domains that you've been looking at?
Not to put me on the spot or anything, right? So I mean, behavioral health workforce, like access to care is such a huge issue. You can't talk about any of these things without talking about access to care. And workforce is such a critical piece of that. I think the challenge in answering your question is that there's no one silver bullet. There is no one silver bullet. And honestly, the thing that would have the biggest impact across everything that we just talked about and across almost everything in the state health improvement plan is funding. And that's a limited resource. So funding to increase reimbursement rates in Medicaid, funding to enhance services, community-based services for children that provide mental health services. Funding is what we need. We need additional funding. And that is probably one of the most significant limitations in Nevada because of our tax structure. So unless we can find a way to pull more money out of somewhere, I think that's going to be a challenge that we continue to face. I think some of Dr. Packham's slides are telling in that when we have more money, we see a difference. We see whether it's an increase in reimbursement rates in Medicaid. John said, if you build it, they will come. If you pay them, they will come. If you want more people to provide Medicaid services, pay them appropriately. If you want to build GME programs, provide the money to do it. If you want to expand nursing programs, pay nursing instructors more money. And also there's other things you could do, but so much of it comes down to money. So I can think about it a little bit more and come up with other responses that aren't money, but the bottom line is money.
Thank you.
Commissioner Davis, go ahead.
Yeah, thank you for that information as well, too. And I definitely appreciate it. And one thing that just strikes me with the conversations we've had today is that, and maybe we have this already somewhere, but a network the tutorial or something to pull all our information together in one area, because I think a lot of times we don't have to recreate the wheel, but we have to move the wheel. I think that's probably the goal of this commission. And so we have resources everywhere that I think that we're just not even aware of. And so if there's an opportunity for us to pull together some type of resource that we could have together to really talk about, the different pipelines, the different activities that we can gather data from and move forward with, I think we can do a lot together than we can do apart. And I see in our state, that's what we're going to have to use. The resources that we already have, use them differently. And come up with those types of pipelines. So I really appreciate, hearing what you had to say and all the things that have been done in the workbook, the study, the guide that you shared on there. I think we all need to just study that and look at it. And I definitely will be pulling it up to understand it a little bit more. But I think we can, if there's some type of resource that we can pull things together to understand what resources are really truly available in the state of Nevada, would be very helpful for me and I think for all of us to pull together the action plans that's warranted in the future with our recommendations.
And Commissioner Davis, if I can respond to that, I completely agree. And that was the impetus behind the workforce work group, was to try to compile some of that information. It's not full, it's not comprehensive. It was as comprehensive as possible at the time. And perhaps there's a role for the PPC in pulling that information together or building on what's already created. I would say also on that, like a lot of our work ended there because of lack of funding. So again, it goes back to money. Like if we want to do that, like if the PPC can do it, great. Otherwise, let's figure out where funding is and how we create some sort of hub that is the source of information that is aware of all the things that's happening so we can build on them instead of recreating them. Agreed.
I agree. Thank you so much.
Thank you. Commissioner Khan, go ahead. You're muted, Flo.
I was just saying thank you, Megan, for that presentation and for doing it so quickly. A lot of information. Totally agree. We hear it all the time. Funding, funding, funding. My question to you is like looking at ways, I mean, there's the limited amount of state funding, right? So when you look at some of these, are there other funding mechanisms out there? Obviously, you can draw down federal funding for certain programs, but really going to the private sector and looking at private sector investment in some of this stuff. Have there been other programs that have utilized or have collaborations with the private industry that have resulted in funding, an additional funding source, or an ability at least to draw additional either federal or state monies into these programs? And if so, what do those look like and how successful have they been?
So really great question. Don't know that I can answer it fully. In terms of first part of the question, sources outside of private funding, we can absolutely look at existing funding and how we get more creative. For example, I know Medicaid is working on figuring out how to draw down more federal funds. So that, so that we get those state matching funds for a lot of that. And Stacey Weeks and her team, I'm sure, could provide more information on that. At one point, the legislature, I know Senator Spearman proposed a bill, and I can't remember if it passed, that related to public-private partnerships. And I would have to look back at that. I think it's been done to pull in more private funding. I don't have good examples of what that is, but I think that's the type of innovative thinking that we need at this point. What are the potential sources of funding? Like, what are they? They're public, they're private, they're philanthropic, and who could we potentially approach in Nevada? What could those sources be? How have others done it? I mean, I think all of those questions need to be asked, and I don't have examples off the top of my head. I think philanthropic funding, we've seen good work in the past. I know the Redfield Foundation supported, Dr. Packham did a nursing conference or like summit a couple of years ago that looked at nurse workforce shortages and identified 11 or 12 recommendations specific to that workforce. So if we can tap into in-state resources, folks who are interested in that type of funding, that might be an option. I don't know, let's talk to the Nevada Hospital Association, Pat and his team, and say, like, what would hospitals be interested in? How could we put something together where we're braiding streams of funding to fund this type of initiative? I think it's getting really creative and brainstorming.
Thank you.
Thank you. Any other commissioners? Andrea Peterson, go ahead.
Yeah, and this might be a bit of a Medicaid question, but I'm just wondering, do you know if there's been anything looking at maybe directing the managed care profit sharing to to workforce development revenue stream in that next contract? And I don't know, this is kind of, just as we're talking about money, just kind of a thought. And I don't know if anybody's looked at that at all, but.
Yeah, I think great question. That's the type of question to ask. Like, can we do that sort of thing? But I don't have the answer. I don't know, Joseph, if there's others on who would have the answer.
Yeah, I don't know, Joseph, maybe we could potentially have Medicaid
I know,
address
I know that.
us.
Thank you, Joseph Philippi, for the record. I intend to have representatives from Nevada Medicaid present to the commission on different initiatives and possibilities. So definitely something we can bring before them, and happy to have them include that in the discussion. But yeah. So for a future meeting, can probably delve into that a little deeper.
Thank you.
Any other questions from commissioners for Megan? All right, Megan, thank you so much for your time. Moving on, I believe this is our last agenda item before public comment. We have Dr. Sarah Hunt and Dr. Paul from the University of Nevada, Las Vegas, UNLV. They're going to provide a presentation on behavioral health care workforce development initiatives and policy considerations.
All right, I'm going to pull up my slides here, and clearly you all have saved the best for last. So let's see, sorry, let me just pull over here, and here we go. All right, so my colleague and I are very happy to be a part of this conversation today and be amongst the featured speakers on this agenda. So I'm Sarah Hunt, and I'm the Executive Director for Be Here Nevada, and I'm also joined by my colleague, Dr. Michelle Paul, who's the Assistant Vice President of Mental and Behavioral Health at UNLV and the Executive Director for UNLV Practice. So hopefully my slides are up. All right, I'm not going to spend a lot of time on this slide. I think we're all very aware of the shortages of mental and behavioral health professionals across the state. So let me tell you a little bit about a successful policy endeavor that came out of the last legislative session, which was Assembly Bill 37. And this was a bill brought forward by the Rural Regional Behavioral Health Policy Board. And it essentially establishes a designated behavioral health workforce development center under the Nevada system of higher education. The idea for this model came from a very successful model in Nebraska that's been in existence for over 10 years. And they focused on building their own mental and behavioral health professional workforce pipeline. So that is what's reflected here at the bottom on the graph. So the idea for this bill and this workforce development center is to really start going out and presenting the seeds for working in mental and behavioral health and the education pathways in that K through 12 space, providing a well-lit pathway for those students into our higher education system to train them to be the future mental and behavioral health professionals, provide a warm handoff then from higher ed to professional licensing and professional practice. So again, this passed out of the last legislative session with a fiscal note for over $2 million for the first biennium to get this center up and going. So another quick summary of the bill, when we think about that pipeline development, the way I kind of conceptualize it is focusing it on 3 chunks of that pipeline. So Assembly Bill 37 requires us to go out and do that outreach and education in the K through 12 space, where I'm a psychologist by training. Historically, mental and behavioral health has just not shown up in that space to talk about our career options. The rural board also felt it was important to provide the same kind of outreach to potential adult learners. So those individuals who may be working in entry-level healthcare positions already are looking for a career change, provide that same outreach to them. At the education level, we are already in discussions that we know we need to probably look at expanding our training and higher education. That may look like adding new degree programs that could help fill in the workforce needs without requiring a graduate level education. But also making sure that within our Nevada system of higher education, those individuals who maybe start their career path with a mental health tech certificate program at College of Southern Nevada, that whatever they did there would easily transfer to UNLV if they wanted to come back into the higher ed system and become a social worker. And then that retention piece is very important. So once we've trained these brilliant minds, we want to figure out the best way we can encourage them to stay and become a licensed professional within the state of Nevada. I'll also note that the rural board wanted to see a business technical assistance branch in this workforce center. So the idea there is, for example, if you were coming from out of state and wanted to open a new mental health clinic in the state of Nevada, a place to go to find out some of that essential information, like how do you get your business license? Who are all the licensing boards for professions in the state of Nevada? That type of thing. So what have we done to implement this? What needed to happen next after the legislative session is, again, since this is an initiative that lives under the Nevada system of higher education, the Board of Regents needed to designate one of the universities to serve as an administrative hub for this workforce center. So UNLV provided a proposal to the Board of Regents and they accepted that and designated UNLV as the administrative hub for what is now called the Behavioral Health Education, Retention, and Expansion Network of Nevada, which shortens very nicely to Be Here Nevada. That is our workforce center. So since that approval, what we have been doing here in the Be Here offices has really been focusing on hiring and bringing on staff to do all of this work. Developing our outreach and marketing, including launching our website. We needed a place to bring interested students, individuals to learn more about our pathways, doing follow-up presentations or introducing the bill to new stakeholders. And we've done a series of listening tours with our Nevada System of Higher Education academic programs. So we really wanted to meet with those that are running the mental and behavioral health training programs to find out what connections they already have to the local K through 12 system, but also what issues they're seeing with their graduates either moving on to another institution or moving into employment in Nevada. What's next? We have already, I'm happy to say we've already shown up at 4 different high school career fairs just in the past 2 months to start talking about mental and behavioral health professions. So we are going to continue a lot of that outreach. We've been happy to partner with our area health education centers on some of those, building those connections to K through 12. We want to continue collaborating with our higher education training programs. We've got to move on to data collection and really getting a clearer picture of our mental health workforce in Nevada. So that includes an upcoming partnership with Dr. Packham's office and working with them on that. We've already been looking at grant opportunities. We know there are federal grants that come out related to behavioral health workforce development, so we're keeping an eye on that. And part of the bill requires us to submit a yearly legislative report to give everyone an update on what we've been doing. So we are working on that. In the upcoming fiscal year, we want to build out our initiatives on that retention side. So really starting to work with our higher education programs. We've already started a series of meetings with the licensing boards to kind of hear from them and work on building that technical assistance program. And one of the things that we've got to do is, continue our conversation with the Nevada System of Higher Education to make sure we're added in their budget requests in the next legislative session. So with that, I'm going to stop there and hand it over to my colleague, Dr. Paul, to talk a little bit more about what we've been doing specifically at UNLV around mental health workforce development.
Thank you, Dr. Hunt. Thank you for inviting us to speak to you today. I'm Michelle Paul. I'm excited to actually finish last because I want to build on some of the comments that have already been expressed through questions and suggestions today. UNLV practice, what is that? It is actually an acronym for Partnership for Research Assessment, Counseling, Therapy, and Innovative Clinical Education. And what does that mean? We are an intentionally interdisciplinary training clinic serving the community with quality mental health care while providing the supervised, competency-based clinical training required for our students to graduate and get licensed to become full-fledged mental health professionals in the state. We were established in 2012, and we are guided by 3 principles that are aimed at addressing major challenges that underlie the mental health crisis. Through connection and cohesion, we want to overcome the fragmented nature of mental health disciplines, breaking down silos through an intentional interdisciplinary training program, and through innovation and advocacy, we want to overcome the history of limited funding and under-resourcing of mental health training. Next slide. We opened our doors in 2012 as a partnership between 2 colleges, liberal arts and education, where 3 training programs were separately doing their training: counseling, clinical psychology, and school psychology. Next, click. We are a community mental health training clinic where faculty provide the supervision while the graduate students provide in-person services to the broader Las Vegas community and telehealth services to Elko and Humboldt counties through a partnership with communities and schools of northeastern Nevada. Click. Cumulatively, we have provided evidence-based care over the last 12 years to over 5,000 people across the lifespan. And we've trained over 250 high-level mental health professionals, meaning master's and doctoral students. By the end of our first 10 years, we've expanded our reach to include a satellite clinic. If you can click on that. We have a satellite clinic located in the medical district in Las Vegas, where we have our youth services. And it is because of that expanded infrastructure, thanks to philanthropy, we were able to compete for and receive state and federally funded specialty coordinated care programs for youth as young as age 15, showing signs of early bipolar illness, and youth as young as age 12 who show signs of being at risk for a more severe mental illness, including psychosis. In the next 10 years, we want to expand even further. If you want to give a couple more clicks, Sarah. We want to become a uniquely interdisciplinary mental health institute, and we underwent a strategic planning year last year with the approval of our president and provost, both huge mental health advocates, and with support from Intermountain Health. And I'd like to share with you that vision. You've received a copy of that strategic plan. Go ahead and move on to the next slide. And many of our strategic plan goals, objectives, and tasks align very well with the state health improvement plan you saw earlier. But before I move on to those, I want to give you a high level context of the larger UNLV Academic Health Initiative, which has a goal of aligning all of the health schools in the common purpose of growing a healthier Nevada together. Because there really is no school of mental or behavioral health, as we would find with medicine or nursing or dental health, etc., UNLV Practice has been tapped to be the unit that strategically aligns UNLV's non-medical mental and behavioral health training programs for the greatest impact in addressing Nevada's mental health crisis. Go ahead and click again and again. One more time. Thank you. This truly makes us exceptional in a bold vision to place mental health on equal and collaborative footing with physical health. So bouncing to our first two goals, I just want to touch on them. We are a center of excellence, and we want to remain so with top tier coordination and collaboration. Second one, we also we provide community care, and we want to be, we believe we deliver unmatched community care through fully integrated mental and behavioral health models. Our next slide speaks to that fact. We train students to think now in terms of value-based care. We teach them evidence-based practices, and we also teach them how to engage in routine outcome monitoring. And we're very proud to look at our data and compare it to routine care settings. Our improvement rates are significantly better than routine care settings across both our youth and adult training programs, and we're very proud of that. Next. Our next two goals focus on research. So we want to champion a robust research agenda with an emphasis on interdisciplinary research, and that early severe mental illness research I mentioned before is an example of such a thing. That involves social work, school psychology, clinical psychology, psychiatry, peer support with a partnership with NAMI to wrap services around those at high risk for severe mental illness. That's just one example of a collaborative grant that's both service and research oriented. We're going to expand our trainee workforce efforts by integrating more social work trainees and more couple and family therapy trainees. And we're also working collaboratively with psychiatry and psychiatric nurse practitioners, all with the goal of working together, teaching our students how to work in an interdisciplinary fashion today, so they're not just thrown out into the universe to do it after they graduate. Next. We also want to be a premier advocate and government resource for mental health. We want to be a go-to resource for our community when there are questions about mental health. And last, our sixth goal, we would be nothing without a goal for financial sustainability. We want to diversify and solidify our revenue streams. We are primarily funded now in terms of our expansion by philanthropy and a sliding scale cash pay. And of course, we are subsidized by the programs in the university for our space and some state salary lines for our core staff. That moves us into my last slide, which is policy considerations. As we've traversed our journey over the last 12 years, we've learned a great deal about what it takes to build the mental health workforce. Broadly, it's going to take a strong commitment to center mental health in policy considerations to make our workforce development efforts sustainable and to overcome the decades and decades of stigmatization, undervaluing, and under-resourcing in this area. You've heard much of the data. I've even included a link at the bottom for another report that predicted shortages of 600 psychologists, 630 mental health counselors, just as an example. But we really can't hire or even license our way out of this problem. We have to dedicate resources and shift policies so that we can do what we do very well, not only at UNLV, but across the state. UNR has excellent training programs, and Nevada State University and so forth. We need to be able to train more excellent mental health providers. And in that training world, we've learned that current policy is not aligned with how mental health training models actually work. So someone earlier said, how do we use, maybe if we can't get more resources, how might we use our resources differently? Well, here's one idea. If we could work with insurance companies to get reimbursed for the work that our properly supervised trainees provide, and as I demonstrated to you earlier, it's excellent service. We would like to see some opportunities to explore around this. We currently provide, we can receive Medicaid reimbursement for psychology doctoral trainees, but we would like to explore expanding this to commercial insurance as proposed in the last legislative session. You see the bill on my slide. We would also ask that university-based training clinics operated by accredited programs across mental health disciplines be reimbursed for our services. Again, our services are quality and we have good outcomes. Lastly, in this particular area, there was an Any Willing Provider legislation last year that expanded Any Willing Provider to those faculty who were affiliated with medical schools. Well, most mental and behavioral health training faculty do not have appointments in medical schools, so we would like to have that expanded to mental health clinical faculty. Continuing in this vein, in the training world, we're only limited by our resources. Similar to the precedent set last session for the building of the nursing workforce, appropriations to support and expand mental health training are needed to launch new training programs, and UNLV, as for example, is ready and poised to build bachelor's, master's, and doctoral training. As soon as we have the funding, we're ready to go. To help us sustain our training clinics, such as UNLV Practice, and fill in critical gaps in our workforce pipelines. This has already been mentioned at least once. There was SB 300 last session that could be looked at again. There are currently, for example, 0 accredited residencies for psychologists who wish to specialize in working with children in Nevada. That bill from last session could be looked at again as a starting place for building psychology residencies. And with that, we'll stop and answer some questions.
Thank you so much, Dr. Hunt and Dr. Paul. Do any commissioners have any questions for them today? I really appreciate you sharing your current workforce initiatives and giving the commission some policy considerations. Definitely a lot of helpful data and information shared today for commission members. I think it's a lot to digest, and so with that, I'm sure there'll be opportunities for further discussions and maybe some follow-up after getting to digest some of this information as well.
If
but
I
truly
could,
appreciate. Yes, Dr.
I
Paul,
could,
go ahead.
Joseph, if anyone would like to come to see our clinic and see how we do our work, I would be more than happy to offer tours anytime. I would welcome the opportunity to show you what it looks like and how it's done and what we need to do more for the state of Nevada.
Really appreciate that. All right, any questions from commissioners? Hearing none. Okay. We will go ahead and close agenda item number 9. Thank you both for attending today. We're going to move to our last portion of public comment. So once again, an opportunity for public comment. Just a reminder, no action can be taken upon a matter raised under public comment unless it's added to a future agenda. If you're calling over the phone, please press *5 to raise your hand, or if joining by Teams, use the raised hand function. Let's go ahead and see if we have any public comment. Colleen, please go ahead and state your name and spell your last name for the record.
Thank you. My name is Colleen. My last name is Kamenisch, Camenisch. I'm the executive director for the Nevada Physician Wellness Coalition. And it was amazing to hear all of the ideas to kind of develop the workforce pipeline, which is so needed. But also wanting to put the recommendation in to look at health workforce well-being as well. So, for example, physicians die by suicide more than any other profession across the board. And we know, like, the latest statistics are that 1 in 5 physicians plan to leave their current practice. This was in 2022. And 1 in 3 plan to reduce their work hours. So just as we're considering how to build pipelines, also retention matters. And I would encourage perhaps putting this on a future agenda, but also looking at the Lorna Brain Foundation. One of the reasons that providers, whether it's physicians or nurses, don't seek mental health is because of board licensure, invasive mental health questions that they have to keep answering for life. And so they just don't disclose it and don't seek mental health. So that could be something maybe for the committee to look at in future sessions.
Thank you, Colleen. Appreciate that public comment. Anyone else wishing to make public comment today, please raise your hand. Press *5 if joining by phone. All right, not seeing any further public comment today. I believe that that's all we have for our agenda today. As Vice Chair Kirkpatrick mentioned earlier, any future workforce related agenda items, if the commissioners can please just message me offline with recommendations on future topics you'd like for us to discuss. As I mentioned earlier, we are planning to have Nevada Medicaid present, hoping in June, if not at the latest by July, to the commission to help speak to some initiatives and considerations for you. Additionally, I will say that I've reached out to the Council on State Governments to provide a presentation on interstate licensure compacts and reciprocity. They're an organization that reviews and has all the information for all the states regarding the interstate licensure compacts. So just have a presentation on that. Additionally, the National Council on State Legislatures, they provided a helpful presentation to the Interim Health Committee in Nevada that I thought would also be a topic area that would be helpful for commissioners just to see what other states are doing to address their healthcare workforce shortages, what other pieces of legislation that have passed or have been proposed to address healthcare workforce needs. So those will likely be on the June agenda as well, but really welcome any ideas and topics that the commissioners have for future meetings as we work to address the governor's executive order in the coming months. Really appreciate everyone's time today. We're right at 3 hours today, so really full first meeting, a lot to digest, as I said earlier. So appreciate the public attending as well and look forward to future discussions and meetings. With that, I think we can go ahead and adjourn. Thank you all.
Thank you, everyone.
Thank you.